टेस्ट। हेलो। हेलो।
हाँ आ रहा है।
मोबाइल पे नहीं आ रहा। आ रहा है। हल्का है, ठीक है। नहीं नहीं, ठीक है। ठीक है।
I would request the residents to be in the front. Satyajit, sit in the front, man. ठीक है।
वो लिखा हुआ है। हरी जी पावर हेलो हेलो नहीं हो रहा हो गया हेलो हेलो It's a great privilege to welcome each one of you to this live workshop come CME today at ARA. It's your presence only which can make this event a success. I especially welcome Dr. Pradeep Mohanta, Member Scientific Committee AIOS. He has traveled all the way from Kolkata to make this event a success. It is he who initiated this idea of workshop at ARA with his continuous support and guidance. It is nice to see all professors and head of the departments of different medical colleges. Professor Dr. Vibhuti P. Sinha from RIO IGMS. Let us clap for him. Professor Dr. Sudhir Kumar from Betia Medical College. Professor Dr. Asif Sahnawaz from Darbhanga Medical College. Dr. Ajit Poddar, Chief Medical Officer, Akhand Jyoti Eye Hospital, Mastichak. They have come all the way to this city of Aranya Devi to support the members of Sahabad Ophthalmic Society and to bless Dr. Nilesh in particular. I welcome Dr. Satyajit Sinha, Honorary Secretary, Bihar Ophthalmic Society, who took all pains to be here today to bless Dr. Nilesh. Sahabad Ophthalmic Society is always obliged for his continuous guidance and support. At the same time, I congratulate Dr. Nilesh and his whole team of Madhavi Netralaya for organizing this event of live workshop and for giving us this opportunity to be wiser. I welcome the eminent participants present here, Dr. Ajit Poddar, and others will be joining just Dr. J.G. Agrawal, Dr. Satyaprakash Tiwari, Dr. Bandana Tiwari, Dr. Rakhi Kusmes, Dr. Abhishek Anand. I think they will be just joining shortly. I welcome all the members of Sahabad Ophthalmic Society, especially senior members. Dr. Kedia, he was here, he is just coming. Dr. Deepak Kumar. And thank you everybody for your presence and participation in this workshop. I welcome Dr. Ashish Sekhar, especially coming from Darbhanga with his team of 12 for sharing this, his skill. We welcome all the residents, PGs, coming from different institutions, AIMS, DMCH, PMCH, Betia, NMCH. From DMCH, Dr. Neha, Dr. Diksha, Dr. Raju, Dr. Deepak, Dr. Madhuri, Dr. Richa, Dr. Sunal, Dr. Maman Maja. Dr. AIMS, Dr. Mohan, Dr. Renuka, Dr. Salu, NMCH, Dr. Sanjeet Kumar Rai. We welcome you all. And from PMCH, Dr. Muhammad Akhlaq. And from Betia Medical College, Dr. Ruchi, Dr. Namrata, Dr. Snehraj, and others will also be joining shortly. We welcome you all. Your presence in this event made it purposeful. It is you who can make it more interactive. And I will request all PGs not to hesitate in putting your queries before the faculties. I welcome all the operating faculties, Dr. Pradeep Mohanta, Dr. Nagendra Prasad, Dr. Satyaprakash Tiwari, Dr. Sujit Misra, Dr. Satyajit Sinha, and Dr. Nilesh, who will be sharing their surgical skill now onwards. I welcome the media people, they will be joining just now, for giving time for this event and spreading the science in the society. Thank you very much.
you so much sir, for that kind introduction and kind welcome to everybody. And I would personally like to thank everyone to take time to come here and make this event a success. Dr. Pradeep sir will be starting with his talk first. I will be talking about all the various chopping techniques that this is meant for residents, but I think everybody will be learning from Stalwart Legend. So thank you so much for coming here, taking all the pains and coming and blessing us. Thank you. Cheers first. Please. Thank you. I would like to speak this.
Okay, fine, fine. Thank you very much for having me here. Very good morning to all of you. Particularly to Dr. Nilesh. I just asked him, is it possible to hold a live surgery session in your hospital? Immediately he took the idea, and now we can see a group of people and bright PGs here. If we can make some changes in their decisions in future, that will be a great success. The mission of my life is to make good surgeons. And for more than 10 years, maybe 12 years, I have been sharing whatever I know to make good surgeons. I don't want to show magic in my surgeries. I just share unedited surgeries, including complications, so that every new surgeon can follow them and do good surgeries. My sincere wish to all of you to always strive to be a better surgeon, so that through your hands, thousands of patients will get good vision. And I am deeply humbled by support from all of you, all colleagues, all senior and friends, all seniors and friends. Everybody supported me in the last election to become a member scientific committee. Thank you very much from my heart. Okay, my topic is chopping techniques. First, before we enter into the eye, we enter into the antechamber with handpiece, we can divide the nucleus into pieces by a pre-chopper. We know of many pre-choppers. Dr. Akahoshi in Tokyo have been using it for many years. He has his own pre-chopper. I tried that. I didn't find it good in my hands. Then Dr. Sohail came from Nanded, Maharashtra in one of the conferences, and he said he is developing a pre-chopper, and he asked me to try it. And I found that very good. And here is Dr. Sohail's pre-chopper. After hydrodissection and nuclear rotation, you go into the eye with the pre-chopper, engage it just in front of the main wound. The sustainer hooks the opposite equator, and you divide the nucleus into two halves. Then one heminucleus, then another heminucleus. This is in real time. And now just think, if you want to do this by phaco handpiece, how much time you will spend. So, and now one by one we can pick up the pieces and emulsify. And now I came up with my own pre-chopper. The reason is Dr. Sohail is selling in pairs, 2 pre-chopper and 2 sustainer together, and the price is not welcoming to many colleagues. So he has a patented device, so we cannot copy that. Then I found that, is it necessary to make a curve? Let it be straight. The front edge is cutting edge, back edge is blunt, and sustainer remains the same. Let us see how it works. I just developed it 2-3 weeks ago, and here it is. It is straight. 1.75 millimeter tip length is the pre-chopper. Sustainer is 1.65 millimeter, and here in the same way we can divide the nucleus into 4 pieces. Even if we divide the nucleus into 3 pieces, then it is also very good. And after this, we can emulsify the pieces, pick up the pieces each one by one, and emulsify. Let us see emulsify. Okay. Now this is known to us, stop and chop technique. We make a trench, divide the nucleus into 2 heminuclei, hold each heminucleus with vacuum, and chop. This is for the beginners. You start with divide and conquer, and then you do stop and chop, then you go for direct chop. This should be the ABC of phacoemulsification. With divide and conquer and stop and chop, you understand the machine, you train your foot, you know how much to press to get adequate amount of ultrasonic energy. So all these things, and you are far away from cornea, so you learn to make a trench. Make the trench with low vacuum, adequate ultrasonic energy. Ultrasonic energy is less if the nucleus is soft, grade 2 or grade 3. If the nucleus is harder, say grade 3 plus, grade 4, then you use more ultrasonic energy. After going to a depth where you can see faint red glow at the floor of the trench, you divide the nucleus into 2 heminuclei, and now you go to higher vacuum. Hold each heminucleus at the central hard part and chop each heminucleus. And after chopping, you emulsify the pieces with ultrasonic energy. And now we go to soft cataract, mechanical chop by a chopper which I designed. Mechanical chop by Neto chopper, which is has been designed by Dr. Neto Rosatelli of Brazil, and we will see spin and wedge chop. This is mechanical chop by my designed chopper, Mohantas chopper. This is a very small chopper. Tip length is only 0.65 millimeter. It's stouter and thicker than a Sinskey hook, and it is blunt all around. So you just engage the tip and be in irrigation at the center, or very mild vacuum, and you go to the periphery and come to the tip. This is mechanical chop, means you are not using high vacuum to hold the nuclear mass. The reason is, if you use higher vacuum, what will happen? You will just eat up the matter in front, eat up the lens matter in front, and you will not hold anything. So don't use any vacuum, just support with the tip of the phaco and chop. And now mechanical chop by Neto chopper. So now Dr. Neto Rosatelli uses a long chopper. This is the chopper. It is 2 millimeter or 2.25 millimeter long with a ball. It's very thin, and what he does is he engages and spins the nucleus several times. The reason is, with this, all the cortex gets detached from the capsule, and at the end of the surgery, you will see that there is no cortex left to clean. So this is the purpose of spinning. So this is, you don't use any vacuum in this, just support the nucleus, hook the equator, and chop. This can be used up to grade 3 Even Dr. Neto uses for even grade 4. He uses this kind of chopper. Spin and wedge. In wedge chop, the phaco handpiece is turned, the bevel is sideways, so it becomes like an wedge. The chopper, a ball-tipped chopper, spins the nucleus clockwise and anti-clockwise several times, uses the chopper in this way, bevel sideways, it becomes an wedge-like thing, and the nucleus is chopped. So you don't, it's very safe. You are not using any vacuum, just supporting the mass in front by the handpiece. And now we go to direct vertical chop. After rhexis, hydrodissection and nucleus rotation, we clean the superficial cortex, engage the tip, and the chopper is placed just in front of the main wound, in front of the phaco tip, and we chop. This is not a sharp chopper, but still it can do the job. And now for beginners, you may find difficult to make this direct chop, so you can start in this way. After hydrodissection and nuclear rotation, you clean some cortical matter with bevel down. And now you make a pit or a crater just in front of the main wound. At this time, you are in sculpt mode. Sculpt mode means vacuum is very low, maybe 50 to 90. Ultrasonic energy is always according to the hardness of the nucleus. You make a sculpt just in front of the main wound and make a crater and leave lot of hard matter in front so that you can hold it nicely. And this is, you try this in grade 3 onwards. Now bury the tip into the substance, come back to vacuum, hold it, keep holding, don't release the hold, and chop. What mistake we do is, as we hold, we release the hold and try to chop, and everything gets detached. And now I am towards the end of my presentation. This is the last slide. And submarine chop. This is the technique I devised, not to do trench and to divide the nucleus faster. This is grade 4 plus or grade 5 nuclear sclerosis. Some superficial cortical lens matter is removed. At this time, the tip of the phaco needle is exposed about 1.5 to 2 millimeter. And now the bevel is, handpiece is turned to make the bevel up towards the corneal endothelium. And now we bury the tip completely into the substance of the nucleus, go through the substance of the nucleus as a submarine moves through water. Reach near the opposite equator, and as it is just at the end of the hard part, I stop there and use the chopper to get a nice crack. Rotate it 180 degree and divide it. And each heminucleus is then subdivided. Thank you very much for your attention.
Thank you so much, sir, for that detailed presentation on all the various techniques, and I would like to request you to do this initiatives.
So, wonderful presentation on chopping techniques, sir. Incorporated nearly everything, every way of doing the chopping. And
Hello. We are not using ultrasound to divide the nucleus into pieces. So there is no chance of wound burn or endothelial cell damage because of ultrasound. And it is very safe. The tip which goes down, it is blunt. Only the front edge is sharp, cutting edge. And the sustainer, if we learn to hook the equator, it is between two instruments. So it's very safe.
But you need to be in the center. If it is on off center, then the torque may make it difficult,
Yes,
difficult
if it
to.
happens, then you just come out, inject visco and try at another place.
Okay.
So if you do this in, say, about 10 cases, you will love it. And you will save lot of ultrasonic energy and you will save lot of your surgical time.
And until what grade of cataract do you think
can
this
do
is
it
going to
easily up to grade 3.
help? Grade 3. Not
After
beyond
that also you can do when you become more experienced. And it is very useful when the zonule is weak. So you are not stretching on the zonule, it's just hooking the equator, and it's very useful in IFIS. You just inject visco, the pupil dilates, you divide the nucleus.
Less amount of maneuver inside.
And you don't use the side port. You just, with single-handedly, you can pick up the pieces, and there will be no iris prolapse through the side port. So in some cases, you will find it so useful.
From point of view of postgraduate, if I had to take a few take-home messages for chopping and pre-chopping, what that will be?
Well,
Like what should be the parameter? What should they do with the parameters?
The first thing is we see the videos and we see the hand movements. We don't see how the foot is moving. So the residents have to spend lot of time with training their foot muscles, the delicate muscles of the foot. You have to learn how much to press. And you have to train your foot in divide and conquer, stop and chop. In this, maybe some 10, 15, 20, whatever number of cases it takes for you to train your foot. Once you train your foot and you find that now you can hold the nucleus very firmly, then you go for direct chop. If you can't hold the mass in front with vacuum firmly, if you release the hold and if you try to chop, it will just cheese well. So, and for pre-chop, if you try maybe after 40 or 50 cases, you can try in an easy way under supervision of your professor.
Another one very important question which usually arises from postgraduate point of view, what should be the grade of cataract which they need to select for the first few cases?
First few cases, always try maybe grade 2 plus or grade 3.
Yeah, that's very important because we feel that soft cataract, it is going to be easier. But soft cataract has its own complications and difficulties also. So the adequate amount of hardness of the nucleus is required when you are starting with, but as sir has said, the foot pedal control is going to be the main key. If you develop a good foot pedal control and good kind of coordination with the machine, hand-eye coordination, then only move toward the phacoemulsification of the patient.
Right.
And one must learn the stop and chop technique and the 4-quadrant technique before moving on to direct chop. I think that's going to solve the problems.
I think Nilesh didn't introduce Dr. Pradeep Mohanta properly, so I have to do the task. So first, on behalf of Bihar Ophthalmic Society and also being the secretary, I warmly welcome you to Bihar, sir. Thank you so much for coming all the way. And for all the postgraduates sitting over here, if you type one name, Pradeep Mohanta, you will see the largest number of learning videos on YouTube. All the surgeries and everything step by step. He is one example of action speaks louder than words. during his All India election, he has become a member scientific committee. I think he must have been one of the candidates who did least campaigning, not doing any campaigning at all. But his YouTubes and his work is known all over the country and all over the world. He has followers from all over the world, and that is why he is the member scientific committee of All India Ophthalmic Society. And it's an absolute honor and privilege for us that he has taken out time and he has come over here. And what a wonderful way he did of trying to find out to make a cheaper chopper available, because the one which was there, he said it's costly. So then he did not stop there, that now I cannot do anything. He innovated a way of how to make it cheaper and how to make it available for everybody. So a big thanks to you, big appreciation for you, congratulations, and thank you so much for coming here, sir.
Thank you very much.
Thank you so much, sir, and sorry, it was my fault. I am very poor at introduction, and I would like to request any resident if they are having any queries to ask, sir. I would like to welcome Dr. Nagendra Prasad, sir, and Dr. Sunil Singh, sir. Welcome, sir, and thank you all for coming from all the way. So we'll be starting with the live surgery soon. The event is sponsored by Zeiss. Zeiss has kindly supported us with all the logistics, and they have provided us with the technology that we are going to demonstrate today. So it is my duty to introduce to all the technologies that we have, and we are very humbled that this is one of the few centers in India which is having all the equipments from Zeiss that creates the cataract workflow, and this is what we have learned or what we have felt in the last few months of using the entire workflow. So these are my financial disclosure. I am a research and development person involved with Zeiss, and these are the components of workflow that is available. It is an IOL master, that is to find out what IOL we are going to put in. Then we have the Callisto. It tells us where to make the incision, where to place the toric IOL if it is there, and to record the surgeries. And then we have excellent viewing system in form of Lumira, and then the phaco machine, that is Quattro 700. So these are the components that create the workflow. So what is the benefit of each of these machines? So Zeiss IOL master family, what we have is IOL 700. It provides precise alignment. It has total keratometry and the anterior keratometry, and it provides also the reference image, which is the starting point for the markerless storing system. So it is the gold standard for biometry right now. And then we have the Callisto Eye, that is connecting all the device to the computer-assisted cataract surgery system, and it gives us the incision position and the toric placement position. And then the entire thing comes into the eyepiece. One of the eyepiece is projected, the overlay from Callisto on via IDIS. And then we have the Zeiss Quattro, that is the new machine, and we will be talking about how the Quattro pump is superior to the available peristaltic and the Venturi pump. So this already I have told. So the Zeiss Callisto Eye, we have to do a referencing image, and then that is matched on table with the intraoperative image via the Lumira Eye. So the benefit of Lumira Eye is that it has these machines communicate with each other, so we don't have to do a single transfer manually. So everything what we take in IOL master goes to the Callisto Eye and comes to comes to the microscope via a LAN cable. So there is less chances of error. So whatever we are measuring, we are providing to the patient. So coming to the Quattro pump is just like how the heart works. It is exactly like that. When the ventricles are expanding, the auricles contract, and when the auricles are expanding, the ventricles contract. So there is a constant hemodynamic control. So BP is always maintained, because whenever we need more diastolic pressure, the ventricles will expand more. So similar to that, it has 4 pumps. There is 2 irrigation pump and 2 aspiration pump. So whenever we need more fluid, the irrigation pump will pump more. When we need aspiration more, the aspiration pump will start sucking out more, create more vacuum. At the same time, because it is both are interconnected, so whatever extra amount of fluid we need from the irrigation, we don't have to set it again, that if we need to increase the vacuum, we need to increase irrigation, it will automatically be compensated. So this compensation helps also in leaks. If the leak is happening and the aspiration is low, then the irrigation is compensated by the same amount. So this is how you can see how it is. When one is contracting, the other is expanding. One is contracting, just like how the heart works. So this provides an excellent chamber stability, just as we get in RBP. So there are total 5 sensors, and then one more thing is automated power on demand. What every surgeon feels when we are when we are aspirating the last piece, there is always a possibility that surge can happen, and because there is no other piece that is holding the PC down, the PC can come up and suck because the surge is happening. So in this, what happens, whenever the occlusion breaks, the power stops. So there is no chance of rent that is going to happen, because there is no power that is being delivered when there is no occlusion. So that gives a total cataract workflow. We assess and educate using IOL Master, then we plan using the Forum software, then we treat using Callisto and microscope and Quattro, and then we make the documentation and check. So each of the surgery that we do is recorded right now because we have Callisto. So whatever, like 3 days before, a rent happened, and I was worried that it happened because I made a second, I enlarged the wound with keratome. So that was my thought, that this rent happened because of that. But when I saw the video, I saw that no, it is because there was a jerk in IOL, and that went and hit the PC, and then that caused the rent. So now I know where I have to improve. So that is the benefit of recording each and every surgery that we have. And this is what our entire OT looks like, full of gadgets because of the Zeiss machines. And this is our experience. We have nil refractive surprise in last 2,500 cases using IOL Master and cataract suit. Recently we had, because of some change in A constant in one of the brands, but none other than that. Toric accuracy is now absolutely good. Then markerless toric system also gives a faster turnaround time with cataract workflow, and surgical time has been down 45% with Quattro 700. And we have efficient phaco and excellent chamber stability that reduce the phaco rejects in our practice. And now just to touch upon this is a new product that Zeiss is working on, and we are very proud that we are the only center in entire Asia, Australia and New Zealand where this research is happening. We are developing this app called as Zeiss Eye Guide that is going to help us counsel the patient. So this is not only just to sell the IOL or just to sell the technology. Zeiss is also working on how to counsel the patient so that they can get the benefits. So what it happens is, you can see when the patient checks in, they have counseling articles, counseling videos, they have eye drop reminders, and they have a schedule, the appointment reminders also. So when they have to come for surgery, when they have to come for follow-up, everything is is there fed on the app, and it is going to be shown to the patient. Yeah. So there is also a checklist. So pre-op checklist, patient can see what they have to do before coming to surgery and what they have to do after the surgery is being done. So, and this is specific for each clinic. So once it is launched, probably by this year end, it will be specific for each clinic. So it gives an edge. So you can say that this is an app that is being developed only for your clinic, and it will have articles, and it will have checklist, and it will have reminders specific to your practice and not to what the central company is pushing. So that way it is customizable and very helpful for the patient. So thank you for your patient listening. Next, after this, we will have a small talk, but a very on a very important topic, that is mastering the rhexis by Dr. Ajit Poddar sir. Ajit Poddar sir is the medical director and currently heading Akhand Jyoti group of eye hospitals. And the sir is based in Patna, but the entire the main center of excellence is coming up in Mastichak. And we welcome sir and thank you sir for coming all the way to do that. And I would like to request all the postgraduate, any queries in between, you can just raise your hand and ask the speakers. So thank you so much.
At the outset, good morning everyone, and I'm really thankful to Madhvi Nitrale and Dr. Nilesh Kanhaiya sir and Rungta sir for giving me the opportunity to speak on the most interesting topic, and in fact it's a most crucial topic, the capsular axis. All the steps of FECO you have seen in when Dr. Mohanta sir was talking about, that you can only do when you have a perfect capsular axis. So, before I begin, the mastering capsular axis, the only thing for the beginners I would like to say that besides knowing all the physics, all the everything, you need to practice capsular axis. Only then you can master it. And the number one, to start with, you watch as many as surgical video, watch your seniors doing the surgery, and you just don't watch how do they do the axis. You watch how do they place their hand, how do they maneuver their equipments and inside the closed chamber. That is more important. When we see the video on the, we don't see how do we maneuver our hands. That is very important. Where do you rest your hand? How do you position the equipment inside the eye? That becomes more critical. Number two, you practice it on anything you have available, like a tomato, like grapes, or anything like that. And then you do the wet lab. And now there are simulators also available. So you can do, and it will give you the how you are performing. There is a performance score on the eyesight simulators, and there are help me see simulators. So, and then you start doing the capsular axis. So, the capsular axis was first developed by the Gimbel and Newhand, and also the Shimizu in Asia. Before that, there was various technical walk technique, the Christmas tree pattern by the Kelman, and then can opener technique was very popular once upon a time. When you do the many puncture in a 180 degree this side and 180 degree this side. So, but what was the problem with the can opener technique? Because there is a V-shaped notch in the capsule, and it has always a tendency to have an errant radial tear. It can go and extend to the posterior capsule. And then the capsular axis was developed. So what is the benefit of capsule? The main benefit of the capsular axis is that the edge of the capsule opening is uniform. So the entire force, whatever you do, whether you do the hydrodissection, you do the hydrodelineation, you do the chopping, you do the cracking, whatever, the entire force is redistributed around the 360 degree. So there is a less chances of radial tear or any kind of things. So it provides you the stronger anterior capsular rim and all the steps you can do. And in the era of a premium IOL, you must ensure whether the IOL is well centered or not. The positioning of the toric IOL, the multifocal IOL, and the it prevents PCO because it covers 360 degree, about 1 to 2 millimeter, 1 to 1.5 millimeter, 0.5 to 1 millimeter of the optics of the intraocular lens. So there is a less transfer of epithelial cells. So, and once there is a PC rent, then it makes a very good scaffold for the 3-piece intraocular lens. And you can, if there is a small PC rent, you can also convert into the posterior capsular axis. So the basic the important thing is, yes, the most important thing is to have a good incision. If you have a bad incision, if you place your incision quite anteriorly, you will be landing into the trouble because you will not have a good maneuverability with the capsulorhexis forceps or cystitome. If you make it quite leaky or you make a large incision, then your viscoelastics will keep on coming out. And it's not the incision is important. How do you maneuver your capsulorhexis or cystitome inside the incision? That becomes more important. You don't need to press the posterior lip of the incision. You have to use it as a fulcrum, a pivot. So try to get the good reflex. If you have a high-end microscope, you will have a good retroillumination. If not, then try to rotate the eye to get the good retroillumination, or definitely you can use the trypan blue to stain the capsule. Do it in the high magnification. Have a good mydriatic pupil, and always maintain the anterior chamber, preferably with the high molecular viscoelastics. So there are various instruments for the rhexis. The cystitome is most commonly used, the utrata rhexis forceps. You can use the combination of the two MICS forceps, fugoplasma blades. The femtosecond laser is an excellent technique. It gives you the predictable, reproducible capsulorhexis of the same size. And there are various techniques, JEF2, Varus, capsule lasers, and aperture CTC, etc. And there are various guiding systems also. We usually prefer the Purkinje reflex, and the center of the capsule. There is a marker also. There is a calibrated capsulorhexis forceps. The Varion, the Callisto you have seen just now. So these are the surgery. This is done with the high-end microscope, where there is a very good retro illumination available with us. So after injecting the viscoelastics, you puncture at the center of the cornea, and your puncture should be deep enough not to disturb the cortical material. Raise a flap and align it and keep it flat on the capsule, and engage with the cystitome and utilizing the shearing force. You keep on rotating the capsule and always finish it outside in. If you will fin inside out, then there will be a notch. There will be tendency to, and you can see there is a 360 degree. You should cover the optic 360 degree around the optic of the intraocular lens. This is with the ordinary microscope when you may not have a very good retro illumination, but you can always, the trypan blue is a very good thing. You can stain the anterior capsule and maneuver we are touching the inner side of the anterior capsule. And this is the local retro illumination device. This is the OmniGlow. This is also works well to get the retro illumination. So इसमें टाइमिंग नहीं दिखाता है. But the ideal size of the capsulorhexis should be 5 to 5.5 millimeter, because the size of the optic of the most of the IOLs is 6 millimeter. But when you have a hard cataract, or if you are doing manual SICS, then you should aim for a larger size of the rhexis. Or if you could, more so in a manual SICS, if you could not make a larger rhexis, make it a oblong. Don't make it a round. Otherwise, you will have a difficulty in prolapsing the nucleus. So the problem happens when you have this type of cataract, the hard intermittent cataracts, the mature cataract with the lot of milky fluid. When we puncture, in this case, when we puncture at the center, we suck with the liquid material, we suck with the same cystitome needle. And you always try to do it with a smaller size. Because once you will try to do it a bigger size, the optimum size of the rhexis, then it may, you don't know, you may, because of the high intralenticular pressure, when the convexity becomes more, and there is a downhill, because of the downhill phenomena, the centrifugal force of the jonular fibers, there will always be a radial extension. So try it with the small and then in a spiral it to make it a large or optimum size. Other way of doing is that this is another hypermature cataract with the lot of intralenticular pressures. There are, when you do with the cystotome, you let it be flat, but when you do with the cystotome, don't make it a flat. You keep it a bit, edge should be elevated, so that it will be easy to hold, and hold it not very exactly at the tear, not away, too much away from the tear. Just near the tear. It will be easy to maneuver. So we started with the smaller size, then make a nip in the at the anterior capsular margin, and you make it a desired size of a capsular axis. So you can always do the capsular axis, always start with the smaller size of capsular axis. You can make it a larger after completion of the first one by decompressing the intralenticular materials, or you can always also enlarge it after doing the surgery, implanting the intraocular lens. Like in this case, we had done the phaco, and after implanting the IOL, we have enlarged the rexis. So, should I stop it here? Because sometimes these are the things when the capsular axis does not go well. Whether there is a peripheral extension or sometimes, like in this case, we had started very well, and because pupil is smaller, so we are going inside the, we are doing rexis underneath the iris, and here it has now extended in the periphery. So the moment you realize that the peripheral rexis has extended into the periphery, don't maneuver. Come out, inject high molecular viscoelastic on the tear, and then do it with the capsular axis forceps. And this is, we were doing it with the shearing force, but when you try to pull it into the center, then you apply the reaping force, because you have to bring it into the center. And here we are doing with the capsular axis forceps, and again, you see, we tried to make it larger at the same set in the one go, but then there is the extension. So this is not the ideal rexis, because we had make a nick in the margin of the at the tear. But and for the beginner, they should not try to do phaco in that case. You could try always to convert that case. And this is an Argentinian flag sign. Sometimes it's very difficult. In spite of all your effort, it happens. And here in this case, once it has happened, inject high molecular viscoelastics, and we try to achieve as much as possible the round rexis we can have. For the beginner, it may not be possible to do phaco in such case, and depends upon the hardness of the cataract. Even I would have not done if the cataract would have been pretty hard. This cataract appears to be soft, so we did phaco in this case. So do it slowly, bring the nucleus out of the bag, because your bag is compromised. And after emulsifying all the nucleus, intraocular lens is implanted, and it is oriented towards the intact size of the rexis. And there is a sign, there is a flap motility sign, because once you have a peripheral extension, you check if the anterior edge is inverted and there is a flutter, then you can think of it's not, there may not be peripheral extension to the posterior capsule. But if it is inverted and there is no movement in the anterior edge, then it may not have extended to the posterior capsule. Then there is a precedent. If it is inverted and there is no movement in the anterior edge of the capsule, then there is chance that it has extended to the posterior capsule. If it is edge is everted and there is a flutter in the capsule, anterior edge of the torn capsule, then it has not transmitted to the posterior capsule. So know the physics, know what is stress and strain, know what is shearing force and what is the ripping force, what are the centripetal force, what you are applying is a centripetal force, what jonular attachment is doing is a centrifugal force. The morphology of the lens, the elasticity of the capsule, the contour and the jonular attachment, how to initiate, how do you orient the flap and how do you hold, that we talked about. And you can do either a push technique, and you do it anti-clockwise, it's a push. When you do clockwise, it's a pull technique. Movement of the instrument inside the wound. Always utilize a fulcrum. Do slowly, keep it, just move your needle only 15 to 13 degree. Don't do it in a one go. And always practice. And it's important to complete the axis. Second is, most important is to complete it. Second is curvilinear. And third important is, if you can make it, it's circular. So circular is not essential. So thank you. Thank you.
Residents, do you have any question?
Yes.
And then I give a nick and then extend. But जब nick देते हैं सर तो वो nucleus होता है वो थोड़ा सा मतलब damage होता है सर तो उसकी वजह से थोड़ा सा vision में
नहीं, निक देते हैं तो न्यूक्लियस डैमेज होता है.
नहीं सर मतलब cortex material थोड़ा सा
हाँ.
ऊपर में आ जाता है सर तो वो
आप इवन जब पंक्चर करते हैं
हाँ.
या फिर अगर आप जहाँ भी होल्ड करते हो तो यू हैव टू बी वेरी पर्टिकुलर अबाउट नॉट टू टच द cortical material. You have to lift the capsular flap only. Second thing, you always inject viscoelastics. People don't. You should have a feel that the AC has become shallow, or you always, whenever you're in doubt, you inject viscoelastics and maneuver the capsule, the flap in a controlled way.
और सर फ्लैप हम लोगों का पोजीशनिंग क्या होना चाहिए मतलब कितना फ्लैप को कितना पास से पकड़ना होता है कितना दूर से पकड़ना होता है सर
You don't hold it right at the tear, but you don't hold it quite away from the tear. You should be about 1 millimeter away from the tear. And it's good to. It is said that it's good to hold at the proximity of the tear, where the capsule is tearing. Number one. Number two, when you do the rhexis, you should always have an eye on where the rhexis is moving, where the tear is happening, not at your needle.
yes.
That becomes a good practice because you miss the peripheral extension only when you don't keep your eye on where the tear is heading.
Yes. Thank you, sir.
In fact, I would like to say Mahanta sir, Nagendra sir, Vibhuti sir, anybody.
What I
can-
want to
yeah.
say is, all of you practice utrata forceps in routine cases also. What you do is you go through side put, use needle and do a nice rhexis. You don't, and when it tends to go to periphery, at that time you take the utrata and you have not taken that instrument in your hand many times. So that instrument is not your friend. So in routine cases also you do rhexis with utrata. Then when you are in problem, you will feel that this instrument is my friend and it can do the job for me. So how to do it? You just go through side put, cut at the center, make a big nice flap to hold. And use the utrata, go through the main port, immediately going through the main port, lift up the anterior wall of the main wound. If you press little bit, visco will come out. Just keep it lifted up, hold it and practice this. In routine cases, you must do this.
So, Dr. Ruchi, I think sir is saying that instead of using a cystotome, PG residents should use Utrata forceps for a more controlled rhexis. That's what you
Yes,
mean,
yes,
sir.
yes.
Dr. Sudhir, your opinion?
Practice both.
Your opinion over
Always
this?
practice both. Be familiar with the both. Cystitoma, because sometimes you will need both.
Yes, they should practice both. If you do 50 cases, 25 cases you do with needle.
Yes, sir. Initially, I think I agree with your advice that the PG residents should start with Utrata forceps for a more controlled rhexis. Later on, they can switch over to that. Anyway, Dr. Nagendra, your take on this?
Yes, it is always better to have a start with the Vitrata forceps, definitely. But it is very difficult to control in as far as the ones who are experiencing for the first time. So you can have a better control using side port and with the needle cystitome and all. Her question is, once we have made the small rhexis, and how to safely enlarge the rhexis and all. So initial cut is very, very important. Once you made the from center to the periphery, that should be appropriate in length. Once you have it made it small, we will always land up in a small rhexis. So it is very difficult to on table to enlarge with one go, unless you make a small nick and then enlarge in a capsule and all. Or if you have sufficient enlargement of the capsule, so you can have surgery. Then after then putting oil, if it is not, then you enlarge preoperatively on the table before the doing phaconucleotomy and all.
Suppose you have done a small rhexis and the rhexis is eccentric. Suppose the rhexis is from more towards the 7 o'clock, and there is a side port at around 9 o'clock or 9:30. So what you do is you take a micro rhexis scissor, which is used in vitreoretinal surgeries. Go through the side port, cut obliquely at around say 6 o'clock, and from there you use the utrata and make the enlarge the rhexis. In some cases, in some positions, you will not be able to use the Vanna scissor to cut. So take that, keep that instrument in your trolley, micro rhexis scissor.
Yes, I have seen Dr. Sudhir doing that. And that micro rhexis scissor, I think Dr. Sudhir had himself was designing that, he was instructing that epsilon person to design one. Sooner or later it will be known as Dr. Sudhir scissor, I suppose. That was a design for this precisely, because you make a small rhexis and then you have to enlarge it. There's a small nick with the micro rhexis scissor and then you enlarge it. But for a PG resident, I think it will be requiring more expertise. It will be, one should not try it initially. Sure. डॉक्टर सुधीर सीजर पर क्या बोल रहे हैं आप डॉक्टर सुधीर सीजर पर
नॉर्मली नहीं स्मॉल बनाइए, लेकिन मैच्योर कैटरेक्ट में हमेशा स्मॉल बना के चलिए, बिकॉज बड़ा बनाने के चक्कर में मैच्योर कैटरेक्ट में ऑलवेज यू विल हैव एक्सटेंशन. क्या सर? एकदम अगर इंटिमिशन कैटरेक्ट हो तो एक गो में बड़ा बनाने की कोशिश न करिए, बिकॉज कब वो पेरिफेरल एक्सटेंशन होगा या कब पूरा टीयर हो जाएगा, यू डोंट नो. सो ट्राई टू गो विद द स्मॉल, लेकिन इमेज स्टार्ट इन द इमेच्योर कैटरेक्ट इन अ रेड ग्लो टेक होगा. आप साइज बनाइए, बनाते बनाते
देयर इज वन वर्ड ऑफ कॉशन आई वुड
Sir, if we have to make oblique rhexis, sir, so whether we should go for horizontal or vertical, is there any significance of that?
You have to make oval.
Oval, yes, sir. Oval, sir.
In oval rhexis is not an ideal rhexis. I am telling you.
Sir,
when
in between
yes,
you
I
are
am telling you that if you have a hard cataract,
yes, sir.
and more so if
for
you are
better
doing
nuclear
manual
delivery, sir, we
SICS.
can go.
For manual SICS, it's recommended that 5.5 to size of the rhexis will not do, because you will have a difficulty in prolapsing them, because you have to prolapse the nucleus in the anterior chamber. So try to make it a larger rhexis, a large circular rhexis. If you could make, then it's a perfect rhexis, ideal rhexis. If you could not make it a circular, then make it oblong or a heart shape, because the area where it is oblong, it will pop out from there. Yes. And then you will.
I think, sir, Dr. Satyajit is saying something
Sir,
for the
better
OT.
nuclear delivery, that will be helpful, sir. But, sir, it is Sir, sir, whether vertical or horizontal, any one of them has got better significance than each other.
Dr. Satyajit, can you hear us?
आप रेक्सिस जिधर से भी शुरू जैसे कि ना प्रायर वंस यू पंक्चर द
Obliquity of the rexis.
depends if you want to make it oblique depends where do you want to make the nucleus pop out. Usually we make it in a 12 o'clock where the
Hello, Pradeep.
in the incision side.
Vertical.
Dr. Satyajit, can you hear us?
Thank you.
So thank you. In fact I should invite the next speaker, sir.
Can you hear me? Yes, I can hear you. Can you hear me?
Thank you.
Can you hear me now? Okay, so one word of caution which I wanted to tell all the postgraduate, Dr. Asif has presented very nicely, Dr. Ajit Podar has presented very nicely and given a nice presentation. But especially when you're doing your small incision cataract surgeries and you want to practice making a rexis first, even before you get on to doing phacoemulsification. In small incision cataract surgery, invariably you will have to make a larger rexis to take out the whole nucleus. And in that, there are more chances that you will lose the rexis. The incidence of losing the rexis will be higher. Now, as a postgraduate, it's very important that you should keep in mind that even though a lot of people are watching you and you may have promised the patient the best of the lenses, but do not bring your ego in between. At some point of time, if you feel you are totally losing it, there is absolutely no point in trying to pull the rexis inwards, trying to save it, and you may be doing more harm to the zonules, and eventually at the end of the day, the IOL stability also gets affected. So if it is getting extended, go ahead, do a can opener. Anyway, you have given a peribulbar block. Anyway, you're doing a small incision cataract surgery. For ages, for many, many years, SICS was done with the can opener. It's very important that you have to give good vision to the patient rather than making sure that you make a complete rexis. And of course, if you feel that you will be able to complete the rexis and the pulling part with the Utrata forceps, as Dr. Pradeep Mohanta was saying, then you can go ahead and do that. But keep in mind that at any point of time, for the patient safety, converting to a can opener is not a bad idea.
Slowly, we are forgetting the art of doing can opener and other things. As a teacher, I want to say if in the second year of your post-graduation, if you are making a small rexis, be happy with that. Just give 2-3 minutes relaxing incisions and take out the nucleus and kind of make the cardiac. But slowly and slowly, you are naturally going to get feel how to enlarge the how to make adequate size capsule rexis. So one trick what MaNeFest told us that the first incision, the length of incision which you make, that determines how big capsulorhexis you are going to make. Number two, the cystitome is always going to make a little smaller rexis as compared to Prata or but you need to understand that Alipurka forceps and that Utrata forceps, they are very good instrument while retrieving the extended rexis. So retrieval of the extended rexis is not that easy with cystitome. Rather, it is more comfortable. You can do that with Utrata or Alipurka forceps. So one need to understand the advantages and disadvantages of these different techniques. But be happy with a smaller rexis also. Once you have done a smaller rexis, just go inside, make a small nick, oblique nick, not a nick which is exactly perpendicular. Make an oblique nick and then create a smaller rexis. Even if it doesn't complete well, no issue with that. If it makes an oblique kind of capsular rexis, don't worry. It is going to come somewhere.
Sujit? सुजीत वाला केस तुम ही कर रहे हो ना, करो.
The concept of this machine is not a pedestal, is not a bench. So, for cost of
क्वेश्चन था कि ऑब्लिक कैसे बनाना चाहिए पूछ रहे हैं ना. एक्चुअली हम लोग बनाते नहीं ऑब्लिक, वो गलत कंट्रोल अगर आ जाएगा आइडियली सर्कुलर बना, लेकिन किसी भी डिजाइन का बन जाए वो कैप्सूल एक्सिस ही कहलाता है. ठीक है, जो आप ऐसे कर सकते हो. रबर का जो बैंड होता है गोल वाला जो, तो वो किसी भी शेप में रहे वो एक्सटेंड नहीं होगा, वो फटता नहीं, इसलिए इसका नाम है कर्वीलिनियर. कर्वीलिनियर का मतलब गोल करनी चाहिए, है ना. इसलिए कैसे बन गया, कहाँ बन गया, इस पर नहीं जाना. आइडिया ये है कि वो मार्जिन कंटिन्यूअस हो, और अगर लास्ट वाला अंदर की तरफ चला गया और अंदर की तरफ ए टाइप का बन जाए तो कोई दिक्कत नहीं. कि सर्किल के अंदर की तरफ, सर्किल के बाहर बन गया तो उसको भी टाइप का बन, वो फिर बेकार है. तो या तो सर्किल बन जाए या फिर अंदर की तरफ वो थोड़ा सा कैप्सूल जी अपना बना. इसलिए किस डिजाइन का बनाए मत सोचिए सर्जन बनाया, वो अपने आप को जस्टिफाई कर रहा है कि मैंने इस तरह से बनाया, वो सब बेकार बात.
Satyajit, can you hear me? How much time it is going to take before we start with the live surgery? Otherwise, we are going to take you for lectures.
I think it's going to take at least 15 minutes for us to start.
So we can move ahead with the
One presentation they can have.
Sudhir sir.
Once we are ready.
The talk is on.
Thank you, Sahabad Ophthalmic Society, Dr. Nilesh Kanhaiya sir, for inviting me for this session. एक्चुअली इतना डॉक्टर मोहंता वगैरह इतना अच्छे ओरेटर हैं, उनके सामने मुझे बोलने में भी भय लग रहा है. नहीं, एक्चुअली फैकोडायनेमिक्स क्या है, जैसे हम लोग इसको हाँ हाँ नहीं 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 पहला वाला नहीं नहीं ऊपर ऊपर हाँ उसमें पावर पॉइंट ये हाँ उसमें आ नहीं रहा है. तो मेरे ख्याल से उसमें शेयर करने वाला यहाँ से देखिए. तो बेसिकली फैकोडायनेमिक्स का क्या मतलब हुआ, मतलब जो मशीन है हमारे पास वो कैसे काम करता है ये जानना है. और इसी सेंस में हम पहला क्या करेंगे, कुछ टर्म्स जो यूज़ करते हैं हम लोग फैको के समय उसको पहले समझने की कोशिश करेंगे. अभी तक हम लोग क्या जानते हैं कि कैटरेक्ट इज ब्रेड एंड बटर ऑफ ए सर्जन, लेकिन जब फैको की बात आती है तो इट इज़ नॉट ओनली ब्रेड, इट बिकम्स केक, क्योंकि सबसे ज़्यादा पैसा देने वाला अभी यही है. तो केक एक इतना बड़ा केक है, एक लालची आदमी कैसे खाएगा ये तो मुझे नहीं पता, लेकिन आम आदमी कैसे खाएगा, इसको छोटे छोटे पीसेज में डालेगा. एक सेकंड, जस्ट एक छोटा छोटा पीस में काटेगा, उसको मुंह तक लाएगा और फिर उसको खा लेगा. लेकिन आपके पास हाथ है, काटा है, काटने का दिमाग है, इस बेचारे का क्या होगा, ये तो काटेगा नहीं, कैसे काटेगा. और आपको ध्यान रखिए फैको का हैंड प्रो इसी सूंड की तरह होता है, तो आपको इसको किस तरह से यूज़ करना है उसको समझना है. ऐसा नहीं है कि लालच में एक के साथ ज़्यादा खा लें पूरा, तो फिर मुंह में अटक जाएगा. इसीलिए बेहतर है कि उसको छोटा छोटा पीस में करना है हमको. तो
इसमें हमको सबसे इम्पॉर्टेंट चीज़ है पेशेंट का प्रॉपर सिलेक्शन करना, वो थोड़ा देर बाद बताएंगे। और लेकिन बिना गुरु ज्ञान नहीं होता। ऑलवेज आपको अंदर से जो पहला चीज़ होगा वो आग होनी चाहिए। यू शुड हैव फायर इन यू सो दैट टू लर्न समथिंग। इतना अच्छा से कैप्सुलर एक्सिस अजीत बताएं, और एक देखने से बड़ा सिंपल लगता है। एक रेजिडेंट या जूनियर रेजिडेंट या हाउस सर्जन देख के बोलेगा सर ये मैं कर लूँ, उसके बाद पता चला कि उस डॉक्टर अजीत को 2 साल लगा था एक्सिस सीखने में। मेरे साथ भी ऐसा ही हुआ था, ज़्यादा ही लगा होगा। खैर आजकल वीडियो वगैरह आ गया, लोग इतना CMEs बढ़ गया तो लोग जल्दी सीख लेता, अच्छी बात है ना। उसके अलावा जो मशीन है वो आपके कंट्रोल में कैसे रहेगा, उसी को हम लोग बोलते हैं नो योर मशीन। तो इसमें 3-4 चीज़ जानना होगा। फेको के बेसिक स्टेप्स में कई बार नाम सुनेंगे, स्कल्प्टिंग या ट्रेंचिंग, चॉपिंग या उसको छोटा पीस करना, क्वाड्रेंट रिमूवल मतलब पीस को अपने मुंह तक ले जाना, और उसके बाद उसको चबा लेंगे पावर से, और जो बाकी कुछ बच गया उसका क्रीम जो मुंह में लगा हुआ रह जाता है उसको पोंछ लेने को बोलते हैं एपिन्यूक्लियस रिमूवल। तो मशीन में 3 चीज़ आप देखेंगे आप। एक तो चबाने के लिए उसके पास है पावर जिससे वो तोड़ेगा, और दूसरा है उसमें पानी जा रहा है, और तीसरा उससे पानी निकल भी रहा है। इन्हीं 3 चीज से द होल मशीन इज गोइंग टू एक्ट फॉर यू, जिससे कि आप उसको काटेंगे, उसको मुंह तक लाएंगे और फिर चबाएंगे। इन्हीं तीनों का यूज़ करेंगे हम लोग। तो एक बेसिक पेरिस्टाल्टिक मशीन में क्या होता है एक्चुअली, देयर इज ए सर्किट, एक्चुअली सर्किट ऑफ फ्लूइड। यहाँ फ्लूइड बॉटल है और यहाँ से यूजुअली ग्रेविटी फेड, इसलिए हाइट पर रहता है वो, उससे ये फेको प्रोब के द्वारा एंटीरियर चैम्बर में जाएगा, और एंटीरियर चैम्बर से वहाँ जो उसको काम करना है करने के बाद वो फ्लूइड फिर दूसरे पाइप से निकल जाएगा। और ये पाइप से यहाँ पर एक रोटर रहता है। ये रोटर क्या करता है, पानी को बाहर पेरिस्टाल्टिक मेथड से बाहर करता है, उसके बारे में हम आगे बताएंगे, और फिर उसको बाहर कर देते हैं वेस्ट में। तो ये सारा मैकेनिज्म आपके पास कैसे कंट्रोल करेंगे। सबसे बड़ा कंट्रोलर तो दिमाग है, वो आपको हमेशा सोचते रहना होगा, और दिमाग को यूज़ करते हैं फुट पेडल से कंट्रोल करते हैं पूरे मशीन को। तो फुट पेडल में एक बेसिक डिजाइन होता है, पहले जब उसमें 3 जगह पर दबा सकें, यानी 2 बार वो दबाएगा। जैसे ही ऑन करेंगे, पहला दबाएंगे तो पानी चलने लगेगा, माने आँख के अंदर पानी जाने लगा। आई के इंट्राओकुलर सर्जरी का सबसे बेसिक चीज़ है कि एंटीरियर चैम्बर कोलैप्स नहीं होना चाहिए। तो यू विल हैव टू फर्स्ट स्टार्ट द इरिगेशन, और जब तक आप बाहर नहीं आ जाते हैं इरिगेशन हैज़ टू बी देयर। यानी सबसे पहले जो शुरू होगा वो इरिगेशन होगा, और जो सबसे बाद में निकलेगा वो भी इरिगेशन होगा। तो फिर उसके बाद उसको जब हम फुट पेडल को और दबाएंगे तो पोजीशन 2 पर आ जाएगा ये, और पोजीशन 2 में ये उसमें एस्पिरेशन एक्टिवली शुरू हो जाएगा। पहले एस्पिरेशन नहीं था, इरिगेशन में एस्पिरेशन नहीं था, वो लीक कर रहा था तो था, अगर नहीं लीक कर रहा तो स्थिर था वो। लेकिन अब एस्पिरेट करेंगे तो अब जो है इरिगेशन बढ़ जाएगा, क्योंकि आप एक्टिवली उसको एस्पिरेट कर रहे हैं। और फेको प्रोब अगर आप लोग देखे होंगे तो उसमें एक प्लास्टिक का स्लीव चढ़ा हुआ रहता है, कलर्ड स्लीव, जो आगे दिखाएंगे। तो उसमें उसके थ्रू वो इरिगेशन होता है, उसमें 2 छेद रहता है साइड से, और एस्पिरेशन होता है स्टील वाले निडल से, जिससे आप रियल में फेको करते हैं। उसमें हॉलो रहता है वो ट्यूब, वो निडल जैसा दिखता है लेकिन रहता है हॉलो, यानी वो पाइप रहता है, तो उससे एस्पिरेशन होता है। और जब तीसरा पोजीशन पर ले जाएंगे और दबाएंगे तो वो फेको का टिप वाइब्रेट करेगा। कितना बार वाइब्रेट करता है, किसी को आइडिया है? 1 सेकेंड में 40 बार। अच्छा, मैं इसका मतलब बहुत ज़्यादा फास्ट है वो। लेकिन फास्ट कोई चीज़, मेटल चीज़ जब वाइब्रेट करेगा तो हीट पैदा करेगा। लेकिन बढ़िया बात है कि वहाँ वर्ल्ड का बेस्ट कूलेंट है पानी, वो कूलेंट भी है वहाँ पर, लेकिन फिर भी हीट काफ़ी पैदा होता है। कभी टच करके देखिएगा उसको ऑन करके, 1 सेकंड के अंदर हाथ जलाएगा वो। तो इसको आपको प्रैक्टिस करना है, बार बार प्रैक्टिस करना है, ड्राई रन करना है। उस समय फेको प्रोब कटोरा वाला पानी में रहेगा, ठीक है। ड्राई रन का मतलब यही हुआ, पूरा सेटिंग कर लीजिए, और फेको प्रोब आँख में न रख के जो बॉल है उसमें रहेगा, उसमें आधा भरा हुआ रहेगा, इसमें टिप दुबा रहेगा, और ये फेको आपको करते रहना। इसका प्रैक्टिस सबसे ज़रूरी है, इसलिए बताया डॉक्टर अजीत ने कि आपको किस फुट पैडल से ही सारा चीज़ कंट्रोल करना है। तो एक बेसिक पेरिस्टाल्टिक मशीन में क्या होता है, ये मशीन का वो एंड है जो कि यहाँ वाला एंड है, हम आपको बताते हैं, सॉरी ये वाला एंड ये है। तो पानी इधर से आता है, तो पूरा पानी खींचने का काम ये एंड करता है। तो इसको मैग्नीफाई करते हैं हम लोग, ये वाला। तो पानी इधर से आता है और यहाँ पर पिंच रोलर्स है, ये रोटेटर जरूर है लेकिन यहाँ पर पिंचिंग रोलर है। तो ये क्या करता है कि इस दोनों रोलर के बीच के पानी को लॉक कर देता है, और ये जब रोटेट करता है तो ये रोलर यहाँ आ जाता है और ये वाला यहाँ आ जाएगा। तो क्या होगा, यहाँ पर खाली जगह पैदा हो जाएगा और इसके चलते ये पानी इधर से इधर खींच लेगा। अब जब इधर से इधर पानी खींचेगा तो नतीजा क्या होगा कि आपको जब इधर से पानी खींचेगा तो एंटीरियर चैम्बर से ये खींचेगा, और एंटीरियर चैम्बर में कहाँ से आएगा, इस बॉटल से आएगा। तो ये एक सर्किट बनते चला जाता है। तो इन्हीं सबके द्वारा हम लोग फैको मशीन को करते हैं। चूँकि ये पेरिस्टालसिस जो इंटेस्टाइन में होता है उससे सिमुलेट करता है, इसीलिए इसको पेरिस्टाल्टिक मशीन बोलते हैं। तो इससे इरिगेशन होता है, बेसिकली है एस्पिरेशन, लेकिन इरिगेशन को भी ये बढ़ा देगा आपको। इरिगेशन तो बेसिकली ग्रेविटी से हो रहा है, लेकिन ये एस्पिरेशन कराने के चलते इरिगेशन भी बढ़ा देगा। तो एक बेसिक तरीका यही है कि इसमें काम करता है। उसके अलावा आपको एक फैको मशीन कैसे काम करता है, उसमें 3 टर्म और आएगा। इसका नाम AFR है, मतलब एस्पिरेशन, फ्लो रेट, वैक्यूम और पावर। इन तीनों को समझना बहुत जरूरी, क्योंकि इसी के द्वारा आप पूरा फैको करते हैं। एस्पिरेशन फ्लो रेट का मतलब पानी कितना आँख में घुस रहा है, चाहे जैसे भी जा रहा हो। तो एक तो ग्रेविटी से जा रहा है, और उधर वुंड से अगर लीक कर रहा है तो अपने आप वो जाएगा। लेकिन अगर हम एस्पिरेशन बढ़ाएंगे उसका, तो पानी बढ़ा देंगे तो इरिगेशन और तेज हो जाएगा। तो इरिगेशन जब तेज होगा तो पानी किधर जाएगा, जिधर से एस्पिरेशन हो रहा है, यानी कि फैको के टिप की तरफ। एस्पिरेशन पाइपलाइन में कहाँ पर था, फैको टिप के पास था वो, सॉरी ये जो फैको टिप है यहीं से एस्पिरेशन हो रहा था। ठीक है, जब इसको ये रोटेटर ज़्यादा तेजी से चलेगा तो इसमें से पानी इसमें जाने लगे, तो पानी ये कहाँ से ले रहा है एस्पिरेशन, एंटीरियर चैम्बर से ले रहा है। तो एंटीरियर चैम्बर में जो भी चीज़ होगा उसका टेंडेंसी होगा फैको टिप के तरफ जाने का। जो भी चीज़ होगा, आइरिस होगा तो आइरिस भी चला जाएगा। इसलिए थोड़ा सोच समझ के करना। तो इसका कैसे यूज़ करेंगे हम लोग, इस पर हम लोग बाद में डिस्कस करते हैं। दूसरा आता है वैक्यूम। पेरिस्टाल्टिक मशीन में आप देख रहे होंगे जब तक यहाँ पानी सप्लाई होते रहेगा इसको कोई प्रॉब्लम नहीं है, लेकिन जैसे ही यहाँ पर हम इसको बंद कर देंगे, यहाँ पर मान लो पिंच कर देते इस पॉइंट पर, तो क्या होगा, इधर वाला पानी तो इधर आ जाएगा, लेकिन यहाँ क्या क्रिएट हो जाएगा, वैक्यूम क्रिएट हो जाएगा। तो ये सक्शन की तरह काम करेगा। तो उससे आगे का चीज़ इसमें जाके फंस जाएगा। मतलब इस टिप अगर इसको यहाँ पर से खींच पानी हटा देंगे तो वैक्यूम बन जाएगा, तो यहाँ पर कोई भी चीज़ होगा इसमें आके चिपक जाएगा। तो ये अंत में कहाँ पर चिपकेगा, लास्ट में आपको फैको टिप पर चिपक जाएगा। यानी जैसे ही कहीं भी ये ब्लॉकेड होगा, मान लीजिए न्यूक्लियस पीस से ये टिप ब्लॉक हो गया, तो इसमें वैक्यूम क्रिएट हो जाएगा और इसी में ही चिपका रह जाएगा, जैसे कि उसको न्यूक्लियस पीस को खींचे हुए है वो। तो इस तरह से इसका मैग्नेटिक इफेक्ट होगा, यानी वैक्यूम से मैग्नेटिक इफेक्ट पैदा होगा जो कि न्यूक्लियस पीस को अपने तरफ खींच लेगा। ठीक है, और जब मुंह के पास आ गया तो वो वाइब्रेट करके उसको तोड़ देगा, और कितना तेजी से तोड़ेगा इसी को बोलते हैं पावर। तो इन्हीं तीनों फैक्टर्स को यूज़ करते हुए हम लोग फैको करते हैं। तो जब मान लो कि इसको पहले से इसके यहाँ पर देखते हैं, तो जब कंटिन्यूअस लगातार फैको चलते रहता है, तो इसको हम थोड़ा सा एक और दिखाते हैं आपको, एक सेकंड। ये वाला वीडियो कैसे चलेगा, है? नहीं बाबू, इसको इस नहीं वीडियो कैसे चलेगा इसमें? अच्छा चलो, नहीं दिखा पाओगे तो हम ही दिखाते हैं। हाँ ये ऐसे काहे कर दीजिए, हमको दिखाइए नहीं दे रहा। हाँ ठीक, हाँ आ रहा है ना। तो ये देख रहे जब कंटिन्यूअसली फैको चल रहा है, तो ऐसा नहीं कि केवल न्यूक्लियस उसमें जा रहा था, वो साथ में जैसे ही अगला वाइब्रेशन हो तो उसको ठेल भी देता है। यानी रिपल्सन साथ साथ रहता है ये, ठीक है। तो साथ साथ रहेगा तो दो प्रॉब्लम, ज़्यादा कंटिन्यूस होगा तो गर्मी पैदा होगा जो कि रेड से दिखाया गया, और साथ में रिपल्सन भी बहुत हो जाएगा। तो आजकल का मॉडर्न टेक्नोलॉजी में दे हैव यूज्ड पल्स, यानी थोड़ा देर चलेगा फिर रुकेगा, थोड़ा देर चलेगा फिर रुकेगा। तो इसमें फैको भी होगा, रिपल्सन भी होगा, लेकिन जैसे ही रेस्ट करेगा तो वो रिपल्सन रुक जाएगा और फिर फ्लो, पानी के फ्लो के साथ फिर से न्यूक्लियस वापस चिपक, फिर से न्यूक्लियस आके फिर टिप पर आ जाएगा, तब फिर फैको अपने आप ही ऑन हो जाएगा। तो इस तरह से इसको एडजस्ट कर सकते हैं, और अगर ठंडा करना चाहते हैं तो और इसको और माइक्रो पल्स में बदल सकते हैं। आजकल का ज़्यादातर मशीन में ये चीज़ रहता है। तो यूजुअली जो फैको होता है, इतना बड़ा न्यूक्लियस है, आपको इसी जोन में रहना है, बहुत ज़्यादा कैप्सूल के पास मत जाइए। इसका बहुत सिंपल रीज़न है कि अगर ये कट गया, टूट गया, तो बाकी सब सॉफ्ट होता है, क्योंकि वो पेरिफेरल है, न्यूक्लियस ही हार्ड होता है। हार्ड को जब आप जीत जाते हैं तो सॉफ्ट इजीली जीत सकते हैं। और एक्सिस तो इसका ये था। इसी में है एक सर्ज। सर्ज का मतलब होता है कि एकाएक एस्पिरेशन तो बाहर पानी ज़्यादा निकल गया, लेकिन इरिगेशन उतना नहीं हुआ, नतीजा होगा कि एंटीरियर चैम्बर कोलैप्स हो जाएगा। लेकिन आजकल का मॉडर्न मशीन्स, जो हाई एंड मशीन्स सभी जगह आजकल उपलब्ध है, उसमें ये सब फेनोमेनन कम है। तो वही चीज़ इसमें ग्राफ से दिखाया गया है। तो अल्ट्रासाउंड काम कैसे करता है, उसका मतलब तोड़ने का मैकेनिज्म क्या है, इसका बहुत सारा थ्योरी है। जो 3-4 मेथड थ्योरी है, उसमें एक जैक हैमर है। इसका मतलब जो आप रोड तोड़ने वाला मशीन देखे होंगे जो कि वाइब्रेट करता है, या डेंटिस्ट लोग के पास कुछ होता है जो दांत साफ करने, उस तरह से ये काम करता है। दूसरा कंसेप्ट है कि स्ट्रॉन्ग एकॉस्टिक वेव भेजता है। अल्ट्रासाउंड का इतना पावरफुल साउंड निकलता है, उससे न्यूक्लियस पीसेस टूटता है। और एक तीसरा है कैविटेशनल एनर्जी, जिसमें कि जब प्रोब आगे जाता है तब तो ये पहला और दूसरा होता है, लेकिन जब वापस लौटता है तो वैक्यूम क्रिएट होता है। उस वैक्यूम के चलते जो लूज कॉर्टिकल या न्यूक्लियर मैटर है वो वापस वहाँ से टूट जाता है। तो इसको बोलते हैं हम लोग कैविटेशनल एनर्जी। तो मान लीजिए कि हम इसको तो इस तीनों चीज़ इसमें दिखाया गया है। सबसे पहले तो पीछे जा रही एकॉस्टिक वेव्स है, और आगे तो टच करता होगा जब न्यूक्लियस तो वो तोड़ता है, ठीक है। टच से पहले तोड़ा और साउंड वेव से भी तोड़ा, लेकिन जब वो लौट रहा है तो लौटते समय भी वो वैक्यूम जो क्रिएट हुआ, वॉइड जिसको बोलते हैं, उसके चलते ये भी टूटता है। ये 3 बेसिक सिद्धांत दिया गया है इसमें। नेक्स्ट कैसे जाएगा? तो इसको हम दिखा चुके हैं रिपल्सन को। तो फेको मोड, इसको भी वही चीज़ है बेसिकली। तो कंटिन्यूअस मोड, पल्स मोड और माइक्रो पल्स मोड अब समझ गए होंगे, इसलिए इससे नाम ही घबराने वाला चीज़ कुछ नहीं है। तो एक क्लासिकली एक सर्जरी हम लोग कैसे करते हैं एक्चुअली, तो सॉरी हम इसको इससे ले लेते हैं। तो कैप्सुलर एक्सिस करना है, आपको ध्यान देना है कैप्सुलर एक्सिस करके। और जो बात उठा था कि किस तरह का कैटरेक्ट सेलेक्ट करना है, तो ये कलर दिखने वाला कैटरेक्ट पीजी के लिए सबसे अच्छा होगा, क्योंकि ये ना तो सॉफ्ट है ना हार्ड है, इसमें होल्ड मिलेगा आपको। उसके बाद जब कर लेंगे हाइड्रो प्रोसीड्योर्स कर लेंगे। हाइड्रो प्रोसीड्योर करने के बाद हम लोग बायां हाथ में चॉपर है, आप डायलर भी रख सकते हैं। और इसमें क्या करते हैं, सबसे पहले ट्रेंचिंग करते हैं ताकि आप न्यूक्लियस के बीच में पहुंच सके जहां होल्ड मिले, और लूज मैटर्स को पहले हटा लेते हैं। तो होल्ड मिला जब, बीच बीच में हवा आते रहता है ताकि आप ध्यान देते रहें इस पर। तो इसके बाद होल्ड जब मिलेगा तो अब हमको क्या करना है यहाँ पर, ये तो काटने का काम हुआ। तो अब मेरा क्या दिमाग में रहेगा, पकड़ ले तो इससे होल्ड कर ले ताकि दूसरा चीज़ से काट सके। तो हम लोग अब इसको होल्ड करेंगे। तो होल्ड करने के लिए क्या करेंगे आगे हम डिस्कस करें। उसके बाद इसको छोटे छोटे पीसेस में तोड़ते जाते हैं हम लोग। तो जितना बड़ा केक खाना आसान से ज़्यादा छोटा केक खाना आसान है, ठीक है। तो छोटा केक जब कर लेंगे ढेर सारा, तो उसके बाद हम उसको अब क्या करेंगे कि उसको मुंह के तरफ लाएंगे। अभी भी काटिए रहा है उसको। हाँ, अब जो है चेंज करना है मैं ये हम अब क्या करेंगे, फ्लो बढ़ा देंगे। तो फ्लो बढ़ाएंगे, जो लूज न्यूक्लियस पीसेस है वो अपने आप टिप की तरफ आने लगेगा। और अपना चूंकि काटना नहीं है इसलिए हमने इंस्ट्रूमेंट चेंज कर लिया, अब वो शार्प नहीं होकर के सिंस्की डायलर आ गया है ये। तो अब ये जैसे ही इससे क्या होगा कि वो मुंह के तरफ आ जाएगा। तो इस तरीक़ा से हर पीस को आप सेंटर में लाना है। आपको मशीन को सेंटर फैको टिप को सेंटर में ही रखना है, इसको बहुत दूर तक अंदर तक नहीं ले जाना है। अपने आप ही पानी के फ्लो से वो खींच जाएगा ये। तो इस तरीक़ा से सारा पीस हम लोग खा लेंगे। अब हम आपको फिर से उसी स्लाइड की तरफ ले चल रहे हैं जहाँ पर हम लोग इसको डिस्कस करने वाले थे कि ये क्या चीज़ है। बेसिकली पैरामीटर सेटिंग उतना डिफिकल्ट नहीं है। एएफआर का काम क्या था, पानी का फ्लो बढ़ाता था फैको टिप के तरफ। तो ये अब पावर का क्या काम था, पावर का काम था वो काटता था। तो जब आप पहला जो ट्रेंचिंग करेंगे उसमें हम लोग कुछ नहीं कर रहे होते हैं, उस समय केवल काट रहे होते हैं, इसलिए पावर जो है ज़्यादा दिख रहा है इसमें, ठीक है। इसमें पावर ज़्यादा दिख रहा है। उस समय हमको कुछ खींचना नहीं है ट्रेंचिंग के समय, इसलिए वैक्यूम का ज़रूरत नहीं है, मिनिमल है। और पानी का फ्लो भी बहुत ज़्यादा ज़रूरत नहीं, क्योंकि हमको टिप की तरफ कुछ भी नहीं लाना है। लेकिन जब चॉपिंग कर रहे होंगे तो हम चाहेंगे कि वो होल्ड करे, तो होल्ड करेंगे तो उसके लिए वैक्यूम हम लोगों ने बढ़ा दिया यहाँ पर। लेकिन पावर का उतना ज़रूरत अभी भी नहीं है, ठीक है। और एएफआर बेसिक पर है। उसके बाद जब खाने का बात होगा यानी क्वाड्रेंट रिमूवल का, तो आपको एएफआर को बढ़ाना पड़ेगा, जो कि यहाँ पर कम लिखा हुआ है लेकिन यूजुअली बढ़ाओ ज़्यादा रहता है ये, है ना। और वैक्यूम का आप ज़रूरत नहीं है, क्योंकि एएफआर खुद ही टिप की तरफ फ्लो करेगा पानी और उसके साथ बह करके न्यूक्लियस मैटर भी चला जाएगा। जैसे बरसात में नाली में देखते होंगे, नाला पानी के साथ साथ उसमें गंदगी भी बहते रहता है, न्यूक्लियस टिप या पीसेस भी फ्लो टिप के तरफ जाएगा। और पावर जितना ज़रूरत है उतना रखेंगे। बॉटल हाइट यूजुअली 65 से 75 सेंटीमीटर रखते हैं, बाकी में कुछ नहीं है। और हमको लगता है कि काफ़ी हद तक समझ में आ गया होगा, हाँ। तो और कोई क्वेश्चन करना चाहते हैं तो बोलिए, कुछ जो चीज़ नहीं समझ में आया हो, या फिर से पढ़ाने बोल रहे हैं। कुछ कोई क्वेश्चन है? चलिए बाद में। बहुत ज़्यादा कर देंगे तो ज़्यादा पानी टिप के तरफ आएगा, तो उसके साथ एसी में जो भी चीज़ है वो भी आएगा, यानी पोस्टीरियर कैप्सूल भी आएगा, आइरिस भी आएगा। अगर न्यूक्लियस आपका किस्मत होगा तो भी आएगा नहीं तो साथ में वो भी आएगा जो आप नहीं चाहते हैं। जी डॉक्टर साहब बोलिए सर।
नहीं, मैं कह रहा हूँ कि डॉक्टर सुधीर, ये जो बुलबुला है वो आपका पेटेंट है क्या? और लोगों के केस में भी बुलबुला निकलता है?
कौन बुलबुला जी? वो वाला
सर्जरी के बीच में पेटेंट है क्या?
बताता है बार बार कि पैसा मशीन का नहीं दिया गया अभी तक
बाकी लोग को भी दिक्कत होता है, क्या है कि बुलबुला न निकले इसके लिए डॉक्टर बोलिए पोद्दार साहब, आपका कुछ टेक बुलबुला न निकले।
ट्यूब से एक्चुअली इसको वॉइड बोलते हैं। जैसे ही जो पीस काटिएगा ना तो सर्ज को रोकने के लिए सिस्टम है, तो वो उसमें एयर बनेगा ही बनेगा। हाँ, एक्स्ट्रा वो सर्ज मेंटेन करने के लिए एयर आ जाता है।
Satyajit, please go ahead. Dr. Vibhuti, can you hear me and see me?
चलिए, थैंक यू। अब आप लोग फेको एंजॉय करिए। आप
Okay, a very good morning to all the audience who are there, all the esteemed delegates from the OR of Madhavi Nethralaya. We have 4 cases lined up right now. First will be done by Dr. Sujit Mishra. The next 2 will be done by Dr. Pradeep Mohanta sir as he has to leave. And then myself, Dr. Satyajit Sinha, I will be doing the 4th case. I must congratulate Madhavi Nethralaya for making a wonderful modular OT over here in Ara. And it's really all the good equipments which are there. It's going to be a treat for all the surgeons to be operating. And now I'd like to request Dr. Nilesh to please give the introduction for the first case, details about the first patient. Dr. Nilesh, please.
Thank you so much, sir. And welcome everybody. We are live from the OT of Madhuri Netralaya. And today's first operating surgeon is Dr. Sujit Kumar Mishra, sir. And he is going to operate on Mr. SK. He is a 16-year-old male who had diminution of vision since childhood. He presented to us around 2 months back with no systemic condition. And his vision was CF 3 meter at presentation. So we are going to operate on his left eye and right eye. Sorry, left eye he is pseudophakic, and this is the anterior segment and the fundus photograph. He has got lamellar cataract with some amount of blue dots. So it's a case of congenital cataract that presented very late to us. And his axial length is around 20.34 millimeter with ACD of 2.98 and a lens thickness of 3.03. And he has minimal amount of astigmatism, just 1 diopter of astigmatism. And he requires an IOL implantation of 33. We are going to implant a C2 Lucia for him. So that's all. We are almost ready with the case. Suicide is draping, and we are going to start.
वहाँ पे उधर है.
Thank you.
ब्लू वाला वो माइक्रोस्कोप में देख के कर लेंगे हम लोग. ठीक है. ये दीजिए मुझे. अब बैठने दीजिए. ये दे दीजिए मुझे. चेयर दीजिए ना. वो दे रहा है सर. दे देगा वो.
So Dr. Sujit Mishra is going to do the first case, and he is in the process of adjusting his chair and table, and he will be operating on the patient whose details you already have. Do we have the microscope view now?
ये माइक को थोड़ा सा मेरे मुंह से अलग कर दीजिए. माइक्रोस्कोप में टच होगा. हरी थोड़ा सा इसको बाहर कीजिए. ये कैप में टच नहीं ना कर रहा है. टच करेगा. हाँ, इसीलिए उसको बाहर टेबल हाइट कीजिए.
Dr. Sujit will be operating on the Quadra 700, which is one of the latest phaco machines from Carl Zeiss. And the core word comes from the quadruple chambers that they have, which is, it's neither a peristaltic nor a Venturi pump. And it works on direct mechanics. Can you...
सामने देखो बेटा. सामने देखो. इधर सीधे देखते रहो. इधर सामने देखते रहो. इधर सीधे रोशनी पे देखो. रोशनी दिख रही है. थोड़ा सा रोशनी पे देखते रहो तो फिर ठीक हो जाएगा. ठीक है. इधर सामने देखते रहो. इधर सीधे रोशनी पे देखो बेटा. नीचे नीचे पैर की तरफ देखो. नीचे एकदम. हाँ, ऐसे नीचे.
So this is a good practice. Once you have draped the patient, it's a good idea to give a complete wash so that if any debris is around, everything gets washed out.
ले लीजिए. बस घबराना नहीं है. आराम से ले. ठीक है. विस्को. विस्को. इधर आ जाइए. इधर आ जाइए. इधर विस्को. हाँ, खोल के देना है ऐसे. हाँ.
Can you see it clearly, Vibhuti?
हाँ, ले लीजिए. आइए इधर आ जाइए. या.
Good. Thank you.
मुझे ये थोड़ा सा नीलेश टेबल लाइट एडजस्ट कीजिए. डीफोकस्ड है. थोड़ा नीचे कीजिए.
इनका माइक ऑन है.
थोड़ा और नीचे. थोड़ा और नीचे. थोड़ा और नीचे, थोड़ा और नीचे, और नीचे थोड़ा, और थोड़ा सा, या दैट्स फाइन. ओके. Keraton.
Dr. Sujit, you will be giving a continuous commentary.
2.2. This is 2.2. 2.4. Is it okay? Zeiss people? Okay, fine. Yeah, just a minute. Just let me have the feel. I will just explain. Just let me. सामने देखो बेटा. सामने देखते रहो. सामने देखते रहो. सामने देखते रहो. Yeah, because patient was a little bit apprehensive. Trip and blue. So I wanted to ensure that I make the wound correctly, because in phaco these are very crucial steps. So even if you are doing, wherever you are doing, in your routine OT or in live surgery, make sure that the basic steps should be pakka. I took air bubble and then I am injecting trip and blue. The reason for using air bubble in trip and blue is that it spreads a thin layer of trip and blue over the anterior capsule. Otherwise, what will happen if you inject trip and blue in anterior chamber directly, the trip and blue will get diluted, so the strength is reduced, the staining property will be reduced. Saline irrigation. Saline? So better you use it.
Dr. Sujit, we had a good red reflex, still you have chosen to put a dye. Any particular reason?
It softens the capsule. One reason. In case of any adversity, I can identify the extent of the capsule. I have made it a habit that I do all my cases. I use trip and blue in all my cases.
That's indeed a very important point, that it does soften the capsule, and in case some inadvertent extension or something happens, it gives you a good view to control it.
Okay. अच्छा, ये HPMC है. अरे वो मतलब I thought वही thicker लग रहा था. So I would prefer to release that air bubble. Okay. हाँ. Saline दीजिए. कॉर्निया पे saline दीजिए. Okay. हाँ.
So anybody from the postgraduates would like to comment? He's a young boy, and what kind of cataract is this? What do you see?
Needle capsulotome. You can see this is a lamellar cataract. Okay, we all know that lamellar is the most common type of congenital cataract. Before doing surgery, I measured the dimension of this lamellar cataract. It is around 5 mm. ये लीजिए, मुझे बनाना है, आप मत बनाइए, मुझे बनाना दीजिए. 26 gauge needle दे दीजिए. हाँ. See, even capsulotome also, I want to make it myself. Needle holder, please. The reason is the angulation of the bend. That is very important. You should not make it obtuse. It should be acute, less than 90 degree. The reason is, if it is less than 90 degree, you can see the bevel. If it is bent too much, then it will be hidden behind the bevel. You can and second bend is near the hub.
So one question for the postgraduate. Young boy is going to do a Rexis. What should he be careful about? What is the extra precaution you have to take in a young person who is doing cataract? What can happen here which would normally not happen in elderly patients?
See, sometimes when it is very transparent, you may not be able to make out where the exactly capsule is, because I have stained, even if there is a red glow, how beautifully I can make out the margins. These capsules will be very elastic, so I should not be puncturing it. And I am open to use of ultra forceps also in such cases. I am not shy of, depending upon the situation. I am not shy at all. If I need, I will use it. And the reflected flap will give you the margin. It will have tendency to go to periphery, so always be careful. Is it centered? I feel sir थोड़ा इधर कीजिए, थोड़ा सा सर XY के बाहर है, थोड़ा सा इधर कराइए। सुलेमान थोड़ा सा सर इधर कर लो बेटा। हाँ ठीक है अभी, ठीक। सलाइन दीजिए कॉर्निया पे। हाँ, अचानक से नहीं, थोड़ा सा सर इधर कराइए। हाँ, यस, हाँ। He is a young child. It's not that I could just make it fast, but spending a little bit of time and doing a round central rexis, that is going lifelong for him. So I tried my best to make a round, beta acne, and I'm doing it under topical. So I didn't mind spending couple of extra seconds for him. And now you see, literally, just my aim was just little overshoot so that I get ये कितना गे नहीं, ये हाइड्रो के लिए ये नहीं चलेगा, थोड़ा सा मुझे थिक कर। क्या दिया है आपने हाइड्रो के लिए? कितना गेज है ये? 26 नहीं, हाइड्रो के लिए 26 नहीं, मुझे आप 23 दीजिए ना। 23 है।
So Dr. Sujit is a well-experienced surgeon, but as in children, in young...
what they have given, I will use that only. But see what happens. 22 है, दीजिए 22 दीजिए. See, for hydro dissection, for postgrad, because postgraduates are sitting, so I don't want to violate any step, If you use a thicker jet, it will have separation property. If you are using a thinner jet, it will have cutting property. So if I am using a thicker one, it will separate easily. Okay, if I use a thinner one, it may pierce the PC. It is not that I cannot do, but I should do it properly. Okay, and a little bit more. Visco दीजिए, थोड़ा इल्यूमिनेशन बढ़ा दीजिए, वहाँ पे तभी जाके होगा, थोड़ा इल्यूमिनेशन बढ़ा दीजिए। इधर देखिए, हाइड्रो दीजिए मुझे थोड़ा, हाँ हाइड्रो दीजिए, तभी उधर जाएगा, ग्लो नहीं आ रहा है पूरा, देख रहे हैं, थोड़ा बढ़ा दीजिए, हाँ ठीक है, दीजिए हाइड्रो दीजिए मुझे, हाइड्रो जो 22 वाला था वो दीजिए, ठीक है, ठीक है, सामने देखिए, I don't know it will go through this or not, anyway I will do little bit of more from this side, okay, because this is very soft, you know, visco. फेको फेको दी, आयरिस रिपोजिटर दीजिए, जो सिंस की दिया वही दीजिए, आयरिस रिपोजिटर हो तो ज़्यादा अच्छा है, उससे वो चीज़ वायरिंग नहीं होगा, आप मुझे आयरिस रिपोजिटर दीजिए. So see, for hydrodissection you have to use flat tipped 22 or 23 gauge cannula, that will give you a good Z, you know. सामने देखो बेटा, सामने देखो, because patient is little bit apprehensive and doing in topical, so I am not doing it from side port, I will try to, ये विस्को है, थोड़ा सा एक हाइड्रो दे दीजिए ना, each and every step, you know, because of change of cannula, everything, दीजिए, वो दीजिए ना. सामने देखिए, just I want to push some saline here, so it should give me some superior hydrodissection. हाँ दीजिए, विस्को दे दीजिए. I can aspirate in one go, but I want to make it the sub-incisional one clear. दीजिए, फेको दीजिए.
Dr. Vibhuti, can you hear Sujit clearly?
हाँ फेको दीजिए ना, ये क्या है, या थोड़ा सा बीच में सर रखिए, नहीं, अच्छा ठीक है, हाँ. So now what parameter you are giving me? हाँ सामने देखते रहो बेटा, ठीक है. This is yes, yes, yes. Yeah. सामने देखते रहो बेटा, इधर इधर देखो, हाँ ऐसे ही देखो, इधर थोड़ा सा सर बीच में कीजिए, मेरे एक्स वाई के एरिया से बाहर है, ठीक है. हाँ, सो द पैरामीटर दे हैव गिवन मी इज 50, 70 वैक्यूम, यस, ऐसे ही रखिए. ओके, टू गेट द फील ऑफ द मशीन आई एम ट्राइंग टू सी. ओके, विद दिस पैरामीटर इट इज कमिंग नाइसली. थोड़ा सा इधर रखो बेटा. ओके, okay, so what I will try, if you turn it down, then that nucleus should come easily. See, you can see, if there was little bit of substance, I could just lift that central nucleus. That is called Fayko lollipop technique, where I could just lift that central endocore. But this cataract is so soft, wherever with low vacuum also I am touching, it is coming in toto. So, but even partially I have been able to lift that by rotating the bevel down. सामने देखो बेटा, नहीं नहीं वही रहने दीजिए, that is enough. You can see how gently I am going. Because I spent some time in clearing that cortex, So with phaco tip only I was able to aspirate most of it. Okay. So visco. Okay. And now I will be doing IA. Now I will tell you, because I have crossed halfway, not halfway, less than that, but basic wound construction. आइए दीजिए ना. So, coaxial. So what I wanted to highlight in this case, see, this case was a lamellar cataract. When I saw first in the morning, Nilesh, we noticed some dots were there. So blue dot cataract was also there. Okay, center में रखो बेटा. So I asked Nilesh, so what is the incidence of coexistent lamellar cataract and blue dot cataract? We were not sure. I was also not sure. I searched, I googled, what I got, mixed variety is there in 23% of cases. Various cases have been reported, like sutural cataract with blue dot cataract. And dear audience, respected seniors and my dear postgraduates, you will be surprised to hear that till date no case report is there of lamellar cataract with blue dot cataract. Worldwide it has not been reported. I rang up, मेरा थोड़ा सा और ये चाहिए, बॉटल हाइट ठीक है? नहीं, थोड़ा विस्को दीजिए, थोड़ा सा एसी मुझे ये लग रहा है कोलैप्स हो रहा है. इसको एडजस्ट कीजिए आप पैरामीटर्स, थोड़ा सा और मुझे इन्फ्लेटेड एसी चाहिए. So dear postgraduates, you please find out, you explore it further. Coexistent lamellar cataract and blue dot cataract. Google says no case has been reported till date. Okay. So I rang up Nilesh. I don't know, I may be wrong, but I am talking to you about the protocol, the procedure. What I did, I rang up Nilesh. Nilesh, did you take photograph, slit lamp photograph of the patient? I'm not saying that if my short time Google may be right only, but I did the procedure correct. If this happens to be the case, then we will have documentation and we can have a wonderful article in iQuest, that is Bihar Journal of Ophthalmology, that is going to reach worldwide. And I'm sure Dr. Pradeep Mohanta won't disagree with me on this issue, sir. Yes. Okay. So that's the way we have to move forward. And while talking to you, I finished cortical aspiration, and now I'll be implanting this wonderful lens CT Lucia that has aspheric surface. I have to put viscoelastic on this. So I'll be putting CT Lucia. Okay, it's a preloaded. थोड़ा सा zoom ये कर लें, दिखाई lens दिखाई देगा. क्या? नहीं ना, तो वो रहने दीजिए वहाँ पे, मुझे दिखाना है ना, मैं इसको लोड कर रहा हूँ. ये मुझे टेबल हाइट नीचे करो नीलेश.
So the model of
so this is CT Lucia, exact model Nilesh will tell. It has a spheric surface with a specially C-designed loop, you know, and what they say, it is designed in such a way that asphericity take care of the mild decentration. It mitigates the effect of mild decentration. I just have to close it like this. Yeah.
So this is a CT
ये
Lucia
plunger यहीं रहेगा,
621.
plunger यहीं रहेगा. Just I have to close it and I have to lift that. इसको lift करना है या बस close हो गया? ठीक है? Oh, it is so easy. You just have to close it. In one of the models, I had to take the flap out. Now you take the table height up. नहीं ऊपर कर दीजिए. Table height ऊपर कीजिए. ठीक है? अब इसको ये किया, center किया. ठीक है? तो will it go with this 2.4? I don't have to. It will go with it now. I will just see, before injecting, I will just see if it is going too much wound assisted, then I won't do. Don't hesitate. कॉर्निया पे सलाइन दीजिए, ड्राई हो रहा है कॉर्निया पे हाँ हाँ
So this IOL is a CT Lucia 621.
इधर
It's
सामने
a
देखो बेटा लेंस
monofocal
डालने जा रहे
hydrophobic
हैं
design in C-loop platform. And the concept is designed to mitigate against potential decentration issues and to confidentiality deliver good visual outcomes. It has refractive stability and it enables centering and also maximizing direct capsular contact. The junction ensures stability,
no,
supporting
the
consistent, stable axial IOL.
you know, it is not good for this. You give me other one. No. You need to have, see, we should always be careful, you know. This will not go with it. That much stress I had done. So ideally, for this lens, you have to extend the incision. Don't stretch the wound unnecessarily. It is not about that whether I am able to put it or not. It is all what has been given, what should be the optimum wound construction, what should be the optimum size. We should all be open to it. Nothing wrong about it. Be confident. Don't shy of it. तो ये कौन सा डी कार्ट्रिज दे रहे हैं हाँ हाँ नहीं नहीं सी कार्ट्रिज अगेन विल नॉट गो लिटिल गिव मी आई विल एक्सटेंड सी विल इट विल गो विथ इट सी विल गो विथ इट इधर सामने देखो बेटा थोड़ा विस्को दीजिए थोड़ा विस्को दीजिए हाँ हाँ मैं फिर इसको अपने से देखूंगा जाएगा तभी मैं इंजेक्ट करूंगा नहीं तो मैं एक्सटेंड करूंगा बिकॉज सी कार्ट्रिज नॉर्मली इट नीड्स एक्सटेंशन अगर ये जाएगा एसी में बहुत यार इतना मशक्क़त नहीं करना है वूंड ख़राब हो जाएगा टॉपिकल में वूंड को इतना स्ट्रेच नहीं करेंगे हम एसी कोलैप्स हो जाएगा ठीक है ना तो क्या है थोड़ा सा मैं इसको एक्सटेंड कर दूंगा पुश करने के लिए जैसे तैसे करना है दैट इज़ नॉट गुड यू एक्सटेंड लिटिल बिट अब देखिए गया ना कोई बड़ी बात नहीं है तो द मैसेज इज सीधे है ना ये हाँ मैसेज इज कि किसी की बात मत सुनिए अपना आँख खुला रखिए और जो सही लगे वो तो इसको रोटेट कर दीजिए तो हैप्टिक जो है आपका जगह पे चला जाएगा देखिए देखिए ये सब मिसमैच है ये जो सडन शूट होता है ना ये किसी की बात पे नहीं जाना है एकदम नहीं जाना है बच्चे लोग अपना दिमाग लगाइए ये सडन शूट जो है मिसमैच कार्ट्रिज और लेंस के गर्थ विड्थ की वजह से होता है ठीक है आप मुझे विस्को दीजिए कोई रॉकेट साइंस नहीं है सामने देखिए लुक स्ट्रेट ठीक है दीजिए सामने देखिए So see, आइए दीजिए 16-year-old child, okay, he's apprehensive, he was shivering. तो हमें considerate होना है सामने देखो बेटा because Nilesh has done wonderful surgery in other eye under topical. So I wanted to have the same standard for his other eye. Otherwise, you know, patient and Nilesh both will not be happy. So I wanted to make it sure that I also do it under topical. I talked to the patient, assessed him. If he was very much apprehensive, then I would have gone for block. Otherwise, you know. So now you can see, because I measured the size of lamellar cataract, that was 5 mm, and accordingly I planned capsular access. I didn't do it in a boom kind of thing in one go I completed the access. No. The result is The rexus is covering nicely all around 0.5 mm on all sides. And I'm going behind the optics to clean the viscoelastics because, you know, young child, lifelong, he should have pristine PC, you know, and then he will always thank Dr. Nilesh, you know, and with blessings of all seniors and Kanhaiya sir especially, it's our privilege that we have been given opportunity to display our skill in front of August gathering. All stalwarts are sitting in the hall, and we have luminaries in our OT itself. So with that, I've come to the end of this surgery. I spent some time in aspirating the viscoelastics so that post-operative, that coagulum is not there. We should distinguish between the TAS and the coagulum that happens especially in winter because the AC visco becomes little bit thicker. ओके इधर देखो बेटा हाँ देखो कितना सुंदर तुम्हारा रेक्सिस चारों तरफ ये हो गया है ठीक है ना and my surgery won't be complete without thanking my mentor Dr. Selva Kesundamurthy, a lion at heart, a dynamic personality who single-handedly started Lotus Eye Care Hospital and took it to the heights of listed companies of Bombay Stock Exchange. So wherever he is, his blessings are with us, Nilesh. I will now close the wound. Okay, immediately I should close the wound. Shallowing is not advisable. थोड़ा सा इधर देखिए देखिए दूसरा मैसेज है टू हाइड्रेट द वुंड दिस इज नॉट द थिंग आई वांट जिस तरह हाइड्रो के लिए थिकर कैनुला चाहिए ना हाइड्रेशन के लिए आई नीड 26 गेज ओके ईच स्टेप यू शुड हैव चेंज ऑफ कैनुला so now I need this thin gauge cannula okay so that I can hydrate it properly. ठीक है थोड़ा इधर देखो बेटा spend time, hydrate it properly. Don't be shy of in spending some extra time और अच्छे से आप इसको hydrate कर दीजिए saline दीजिए whatever whitening you are seeing in 1 hour it will reduce to negligible. There has been a lot of studies on this. Someone used 26 gauge needle to inject the saline in stroma itself. So many things are there, but thing is safety of the patient is most important. This is a 16-year-old child, so there is no point in suturing this wound. Otherwise, pediatric cataract, better you suture. And just at the end, you keep an eye towards the optic also, so that you saw it was सामने देखो बेटा सामने देखो. The capsule, the optic was overriding the capsular axis margin. So I tapped over the optic. So now it is. सामने देखो बेटा, just check कर ले. And once surgery is over, इधर light दिखाई दे रही है? अभी? This is very important step, you know, to ensure that you have not overhydrated. क्या है? Intracameral. तो आप बोल रहे हैं तो मैं लेकिन अब तो फिर से हाइड्रेट करना पड़ेगा ऐसे तो मैं करता नहीं चलिए दीजिए थोड़ा सा लाइन दीजिए दिस इज वन ऑफ द स्टेप यू शुड बी केयरफुल अब सारा हाइड्रेट करके आपने लास्ट में इंजेक्ट कर दिया तो वुंड को ओपन कर सलाइन दीजिए सलाइन वुंड को आपने ओपन कर दिया एसी शैलो हो जाएगा पोस्ट ऑप में आपको जो है ना वो हाइड्रेट कर देना है लास्ट में थोड़ा सा दीजिए in Lotus, Dr. Vasavada had come and at the end pediatric cataract he injected pilocarpine somehow, you know, in live surgery sometimes this happens. And because of that, that hydration was not there, that post-op shallow AC was there. That pediatric cataract, we had to take it under GA. So each step, you know, अब क्या डालेंगे? क्या है? कार्पिनॉल नहीं डालेंगे, मैं कार्पिनॉल नहीं डालता, आप चिंता मत कीजिए, सब ठीक रहेगा। सामने देखिए। तो बच्चों डरना नहीं है, आप जो करते हैं वही कीजिए, लाइव में भी कर रहे हैं, कोई बात नहीं है, नीलेश नाराज नहीं होगा, ठीक है। थैंक यू वेरी मच, थैंक यू नीलेश, थैंक यू। Sorry if I exceeded the time. Thanks.
Dr. Sujit, this is Dr. Nagendra here.
Yes, sir. Good morning, sir.
Very nice Lexis, and you planned your surgery very well.
Yes, sir. Thank you.
The opacity of the lens is definitely going to, despite good glow, it is very difficult to make Lexis because there is a totally dense, there is no glow.
Yes, sir. Yes, yes, yes. Thank you. Thank you, sir.
Just a little query.
Yeah.
You don't inject any intracameral
Moxiflor. Sir, I have stopped.
There is lots of study, and even Dr. Ritia shown the 10 lakhs.
ये दिखाए, जल्दी पैड करेंगे, पैड इसको पैड करेंगे, पैच करेंगे। सर
My OT, it is definitely has reduced my incidence.
पैड करेंगे इसको, पैच करना दीजिए ना उसको, एक कॉटन दीजिए ना, पूछेंगे। सर देर इज नथिंग गोइंग अगेंस्ट इट, देर इज नथिंग, इफ समवन वांट्स टू यूज इट लाइक हियर Nilesh uses, so I was not shy of using moxifloxacin. There were many steps where I changed, like when it came to pilocarpine, I simply refused, but when they gave me moxifloxacin, you saw, sir, I didn't refuse. So that itself explains that I am not against it. नहीं पैड दीजिएगा ना, पैड है इसमें, हाँ ठीक है, तो I didn't refuse it. हाँ, for me, sir, initial 3 years around 2006 to 2008 or 9, I used intracameral vancomycin. That time moxifloxacin was not in vogue. Later on, for 3 years, I used intracameral moxifloxacin. When I started my setup, which is almost 8 years now, because everything was under my supervision, I knew each and every step and condition of each and every instrument. It was under direct supervision. So I stopped. I didn't use. Last 8 years, I am not using it. But if someone wants to use it, I have nothing to say against it, sir. Very valid point.
Okay, thank you, Dr. Sujit.
Sir, may I have one query, sir?
Yeah.
I'm Satyaprakash, sir.
Yes, I can understand. I can recognize your voice as PT.
Thank you, sir.
Huh.
Sir, just one different opinion while doing that cortical aspiration with coaxial. What
Yeah.
I presume that if we are going with the coaxial, we should tackle first that subincisional cortex, because once the bag is full of cortex and epinucleus, there is a big volume in the bag and capsule is also protected, everything is good, and so whenever we are doing little angulation to aspirate that subincisional cortex, that is very easy, and the capsule is also protected and safe. And after removing subincisional cortex, then we should go for other peripheral cortex to be removed. Once we tackle first that other cortex, then the bag shrinks, the capsule is exposed, and then there is little bit chance or more risk associated when we are aspirating that subincisional cortex in the end. What is your opinion?
So your question has 2 points. One is use of coaxial, and one is use of coaxial, and second is subincisional cortex. So there are many habits that are inculcated to you by your mentor. Dr. Selva K. Sundarmurthy, by manual I knew it's relatively easier, But when I saw my chief doing wonderful cortical aspiration in all kind of cases by coaxial, I made it a point that I will use it. And believe me, when I started using coaxial, there are very finer points to master, and you can use it equally well. Of course, there will be cases where bimanual is indispensable, and Dr. SPT, you have raised a very valid point, because postgraduates are sitting there. So let me share with you, before I started the OT, I ensured that there is a bimanual. At each step, you should be prepared to compromise with your ego. I ensured that there is a bimanual. If I had any difficulty, I would have used bimanual. Now, what is the difference between use of coaxial and bimanual? See, when you are using bimanual, if you looked at the kind of side port I made, how much I introduced my side port? Just 1/3 tip of it. Why? There is minimum leak of fluid. If you are using bimanual, then what is happening? Either you make the side port larger from the beginning, or you increase it later on. If you are making it in the beginning, then more of fluid leak and anterior chamber flutter will be there. When you are using it at the later stage of surgery, then you can do it safely or you can have some problem. So it is all about whichever way you are comfortable, you can do it. Both are scientifically accepted manner. Regarding first aspiration of subincisional cortex, what keeps the bag inflated? It is not only the presence of cortex that keeps the bag inflated. So at the end, we do PC polishing or not? We go to PC and clean it. So if that inflated capsule is not a plea against aspirating the subincisional cortex first. If you want to hear the flip side of this concept, then you will hear few people saying that more irrigation is going on in anterior chamber. What happens? By plane of natural cleavage, that jet of fluid causes some amount of loosening of cortex, and aspiration of subincisional cortex at the end becomes easier. So there are various aspects of it, and yourself being a VR surgeon, a renowned VR surgeon, I can understand the bimanual thing coming from you. Thank you very much.
Thank you. We'll move on to the next case. Dr. Pradeep Mohanta sir is operating, and I'll request Dr. Nilesh to please give the details of the patient.
Thank you, Suji sir, for that wonderful surgery and all the basic steps that you told. It was really nice. And Pradeep sir has already started with his surgery. He has made the incision and staining also. It is a case of a 50-year-old gentleman who visited us with a vision of CF 1 meter in his right eye. He is having cortical cataract along with grade 2 nuclear sclerosis and some amount of PSC. So you can see there is no fundal glow that is practically possible. Fundus was not visualized. We hope that it will be good and he will get a good vision. Sir will be implanting a monofocal clear lens, that is CT Asphena, in this patient. And more details from sir. Over to you, sir.
Yeah, am I audible? Hello, am I audible?
Yes, sir. Yes, sir.
So the rhexis has been done. Hydrodissection is being done. Okay, Visco.
So your incision is posterior limbal. Anything?
Yes, because I always do posterior limbal. The reason is healing is much better if we include blood vessels. And the first line of defense is neutrophils. So if the wound is near some blood vessel, then the infection control is much better. Now I am trying my pre-chopper. If it works fine, otherwise I will take the handpiece and do direct chop.
Beautifully done, sir. Excellent one. That saves the time and
Visco.
energy as well.
The chamber is shallow, so you come out, inject visco, and you try to chop one more piece. Cut one more piece. And now we go with handpiece. So I am at 450 vacuum, 45 flow rate, and 60% ultrasonic energy. This is not necessary. This chopper is not.
So can you elaborate upon the machine also?
This is Farouz. Now I have taken the Sinsky hook-like small chopper, which I designed. Always bring the pieces at the center and emulsify.
Power?
Power is at 60%.
60% power in vacuum?
Vacuum is 450.
And flow rate?
Flow rate is 45.
So the chunks are very nicely coming towards the tip, and the flowability is also good.
Yes.
So in the last
Coaxial
machine we were using
light.
a 2.4 incision.
Light position 1.
In
coaxial light.
Only this is 2.8.
एक में लाओ उसको.
It has a beautiful chamber stability.
And this part of the epinucleus is acting as a contact lens to protect the PC. And now we go to lower vacuum and emulsify the epinucleus. FECO 3 कर दिया. चलो बस को.
This step is not for beginners.
I was just going to say that.
Simco. No, Simco ready है ना? Simco ready है ना already? वाला.
In the meanwhile, sir, if you are comfortable, can I ask a question also?
Yes.
So my question is regarding the pre-chop. Will you be doing the same thing if you have some kind of jugular?
Jugular means?
Jugular weakness of.
Weakness of patient.
The jugular weakness is there or some.
Jonular. Okay, jonular weakness. Yes, jonular weakness is very good instrument because you are not stressing on the jonule. Visco. কি দেওয়া হবে কি lens? What lens? Yes.
Into the anterior chamber, and there is distortion of the normal anatomy while doing the pre-chop. So,
Keratum.
does that happen?
Please repeat the question. But.
So my question was,
Yes.
there was some kind of distortion of the normal anatomy of the anterior chamber while you were doing pre-chop. So is it normal or it happens once in a while, once we get used to of doing the pre-chop?
Yes.
It becomes more stable kind of the anterior chamber and the
Yes. Initially, you will find that the anterior chamber is getting very shallow, but once you get used to it, you will find that you can chop all the 4 quadrants at one shot. Not this. Okay, fine. This is what lens? This is Aspina from Zeiss, plate haptic lens. Yes, all the haptics have gone into the bag. Sinsky hook. Simco. थोड़ा सा पानी इसमें है. Okay, bimanual ready करो. Bimanual ready करो. Ready है? So I first, by the time bimanual gets ready, I use Simco for cleaning the visco.
In plate haptics, sir, any precaution to be taken while doing air capsule tunnel that being shown that there is a increased chances of into the vitreous going lens to the vitreous will do air capsule tunnel in those cases.
Plate haptic, more incidence of PCO?
Yeah, no, yes, tissue, I'm not sure about it, but if you do yarn in those cases, yarn capsulotomy,
Okay.
there is a loss, there is chances of going the lens into
Yeah, that maybe is. So you do a small capsulotomy. Whenever, if you know that the record shows it is a plate haptic, you do. Okay, give me the hydration.
Pradeep sir, you think there's a definite advantage of a 4-plate haptic over the regular haptics that we have?
Maybe it has got 4-point touch, so it may be more stable in the bag. I'm not sure. What is this?
So you are right, sir. It gives lot more stability to the IUL.
When
we were using a Study XL, the earlier lens from the Zeiss, once it goes into the bag and the anterior chamber are usually more stabilized as compared to the normal hydrophobic or hydrophilic IULs. So the stability of anterior chamber is
Simco, ready करो Simco.
plate kind of haptics.
Simco दे दो.
The only thing we are worried is the PCO rate was very high while we were using the 4 haptic IUL. So
This is the way I form the antechamber at the last.
So this is the kind of slow hydration of the bone.
Yes, and I check if there is any leakage. Then I check if the eyeball is firm or not. Yes, it is. So I close the case here. So I have one more case. I have to move to airport. Is it ready? Is it ready?
Yes.
Okay. Give it.
One important practice which I saw while you were injecting is for the postgraduate also that loading need to be done under microscope, number 1. Number 2, once you have loaded,
Down करो.
try to
नीचे करो chair.
push the IUL 1 to 2 millimeters.
चेयर नीचे कर सकते हैं. चेयर डाउन कर सकते हैं. चेयर डाउन कर सकते हैं.
If it is a forceful kind of plunger, while you are forcing, you are pushing the IUL inside, then be sure that it is catching some part of the haptic or optic and you can do the whole procedure to load the IUL and do the injection. So that's a
डाउन करो.
nice practice.
इसको डाउन करो. हाँ ये डाउन करो. डाउन करो डाउन. It's not happening. दोनों. Yes.
So
Good. इसमें और थोड़ा.
Thank you, Pradeep sir, for demonstrating
Fine. Leave it
such
here.
a wonderful
ठीक है, very
pre-shopping
good job.
technique. And sir is getting ready with his third case. And sir had specifically asked for this hard cataract, which we all fear. We don't want to operate on such cases doing phaco, but sir wanted this because he has developed this wonderful
down
submarine
करो,
chop
chair.
technique, and sir
इसको
wants to
table को down
demonstrate that
करो.
to all
ये
the
chair
postgraduates.
ठीक है.
This case is a 70-year-old female. She came to us with a vision of CF half meter in that left eye, which is getting operated, and it is a hard brown cataract with no visibility of fundus. And sir is going to implant a monofocal IOL. She is having a astigmatism of 1.45, but we have planned for a monofocal CT aspina in her to be implanted, seeing her age and the visual requirement. She doesn't require too much of sharp vision in distance or near. So over to sir for this challenging case coming ahead.
So this is a cataract, maybe nuclear sclerosis grade 4, between 4 or 5. So let us see how it goes. I hope it will go well. Keratom. थोड़ा सा ऊंचा करो, ऐसे. पैराकिन है, पैराकिन. पेशेंट इज स्क्रीमिंग. पैराकिन ड्रॉप है. साइड पुट. ओके, पैराकिन दे दो. 2-3 ड्रॉप्स. साइड पुट है, साइड पुट. फाइन, चलो. एयर नहीं चाहिए. एयर डायरेक्ट चप. डाई. यूट्रेटा. इसको, उसके बाद यूट्रेटा. ये एड्रेनालिन है, एड्रेनालिन है तो दे दो. इसको ऑन करो. So I always wash the dye because and इसको दे दो. विस्को. यूट्रेटा फोर्सेप्स रेडी रखो. मेरा यूट्रेटा है ना. ओके, थोड़ा आई बॉल से थोड़ा वॉश कर दो. ठीक है, कॉटन से थोड़ा. ठीक है, चलो. हो गया. चलो. So now we are going to do rhexis. Since it is a hard cataract, my plan is to do a large rhexis. So adequate rhexis, size of the rhexis may be 6 millimeter. Hydro दे दो. Power 80. फेंको 2 में. एड्रेनालिन है. दे दो. विस्को. handpiece. Handpiece, handpiece, handpiece. चॉपर छोटा वाला, ये नहीं, दूसरा और वो दूसरा. Yes. So we are going to start nucleus management. Am I audible?
Yes, sir.
At a continuous irrigation कर दूं, continuous irrigation. Okay. Now I go in. Focus always. Your focus should be always good. नहीं कंटिन्यूस रहेगा, इरिगेशन कंटिन्यूस रहेगा सारे टाइम. Nucleus is rotating nicely, and now I turn the handpiece, make the bevel up. इसको थोड़ा सा ऐसे रखो, hand should not get, you know. Yes, this air bubble was disturbing. Now I am going to do my technique, submarine chop, where I will go inside, and now I travel inside through this towards the opposite equator. I will stop at the end of the hard part and then make a nice crack. Come to the other side. So huge nucleus, sculpt, hold on side. Yes, and now it is two halves actually. This is, you can say, multi-level chopping. This is the endonucleus. We can remove it now itself. So you break the spine of this. And now, to make space, I can remove one piece. Power कत আছে? Power कितना है? 85 करो. Good. Now we come to the other heminucleus. Go inside it. Go for some distance. Gradually go down and separate. Make two pieces. Yes. Now I tilt it. Bring the apex above. Go just under the apex. Always the eyeball is in primary position. No stress on the wound. This is the last piece. So I am trying to remove the epinucleus out of it and using this epinucleus as a contact lens to protect the PC. I want to use some visco at this stage. एचपीएम से है ना, फाइन. थोड़ा सा विस्कोट दे दो, विस्कोट है, विस्कोट, विस्कोट दे दो. So I'm using some viscose under this to protect the PC and push the posterior capsule back. And over this space, I'm using HPMC. The reason is viscose can block the passage and there can be wound burn, but HPMC will not do that. Echo 3. So we have managed the nucleus. Y hook है, Y hook. विस्को दे दो, विस्को. HPMC, 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 HPMC. The pupil has gone down, so we have to check where we need the cortical aspiration more. Here cortex is there. So all around there are a lot of cortex. You know, Simco, Simco. So I feel good with Simco when I cannot see the cortex. Just go and move it side to side. Yes.
Very well managed axis, AC and nucleus. Can we put some dilator at this stage, phenocaine or
Phenocaine है, phenocaine. लेंस दे दो, लेंस. विस्को. एसपीएम से दे दो, इसको क्लोज करो, इसको क्लोज करो. लेंस क्या है? एस्पिन अगेन.
normally in grade 2 cases, at this stage we say that 60% of work is done. But in such cataract of grade 4 or 5,
Keratum, keratum.
that we understand that more than 80% work is done.
Keratum, keratum, keratum. वाई हुक रेडी रखना. सिंस की डायलर दे दो. Again, they have given aspina. This is not my choice. This is Nilesh's choice. Monofocal, yes. Now I have to check if it has gone in the bag or it is in the sulcus. Visco again. Give the eye hook.
I think you had put triple glue in this case.
Yes, yes, I did.
You used triple glue in all the cases?
No. This case the red glue was not good. So I put.
When red glue is there, you...
Yeah, I don't.
And you use air bubble as well?
Yes, I use air bubble. Whenever I use trypan blue, I use air bubble first, then trypan blue, then I wash off. Fine. Simco. Bimanual ready karo.
Do you agree that this triple blue increases the pliability or some changes in the pliability of entire capsule?
Yes, there are some changes that it makes the capsule such that you can do Rexis easily, particularly in pediatric cataracts. In adult cataracts, I don't find much difference. This is mainly to make the things visible. Okay, chalo. Bimanual de the bimanual. Time क्या है?
You keep both bimanual and Simco ready.
Yes. And Simco is in a different bottle. Simco is attached to a different bottle. It saves a lot of time. It gives some time to your assistant to make the bimanual ready. By that time, you can use Simco to do part of your work. So I go to behind like this, push, gently go behind.
I think PGs should not hesitate in putting that very perfectly.
Hydro. Moxie. This is hydro. How to?
How to regulate vacuum in Pico. When to increase, when to lower. In the last piece, it should be lower.
Yes, in the last piece it should be lower. And the last piece, if you can detach the epinucleus from the nucleus piece, and if you use that epinucleus as a contact lens to protect the PC, then it is better. Simco again. So we are towards the last stage. We have just forming the antechamber and concluding the case. So the technique you have seen is submarine chop, where you don't do trench, you just, without doing trench, you manage hard cataracts.
Dr. Manta, very nicely surgery done. At that point of time when you used Paracan, don't you think that the use of Populin would have been better? Because Paracan, like it was outside.
Already block has been given, sir. The patient was having some pain. Probably the patient is not screaming now. Maybe because of some other issues, psychological or something. Some patients are more sensitive. Okay. Thank you very much. Yes, sir.
Thank you so much.
Yes, sir.
Do you believe in same-day surgery? Means patient turned up same day in OPD and we can do the surgery same day?
Yes, sir. Now the concept has changed. We can control all the microorganisms by application of 5% povidone iodine. So we do same-day surgery. Particularly if we can do biometry by optical biometer without touching the cornea. In those cases, definitely we can do.
But in AIS protocol and Government of India protocol, it is mentioned that minimum 1 day before you must start.
Yes, and all those things will change in time.
So in routine practice, now we have, I welcome you to join the discussion over here, sir. Meanwhile, Dr. Satyajit sir will be getting ready with his case. It is a 60-year-old male with a grade 2 cataract with PSC, and he is going to be implanted an EDOF lens from Zeiss family. So, sir, we are routinely started to use povidone iodine 5% in all the cases. Before surgery, half an hour, we instill 1 drop of povidone iodine. So, is it a routine for you, and how do you?
Yes, it is a routine for me. At least 3 minutes, they say that you should keep the povidone iodine in the conjunctival cul-de-sac. We keep at least 5 minutes.
Sir, And I would like to request from any postgraduates and any senior ophthalmologist also if any question from sir, because sir has a flight to catch, so we will just want to wind up the discussion.
Yes, yes. We put paracaine on drop and then put betadine. Yes, yes, we wash. This is our practice. We wash it thoroughly with Ringa lactate or BSS, whatever is there available.
What are the measures to be taken for the endothelial damage loss with movement?
Damage.
How to prevent endothelial loss?
Please repeat the question. Loss of what?
Endothelial damage.
Okay. For endothelial damage, you should always be at the center where your phaco probe will be far away from cornea. If you go to periphery, the corneal endothelium is much nearer to the phaco tip. Protect the cornea with, if you have viscoat, put a bit of viscoat, and below that you put HPMC. The chondroitin sulfate protects the endothelium better than HPMC. And always take care of your handpiece and instruments. It should not touch the corneal endothelium. And take care of the pieces, hard nucleus pieces. It should not go here and there, and it should not hit the.
Spinning of the nucleus pieces into the anterior chamber is a problem sometimes in really hard cataracts.
Yes, yes. So don't allow the small pieces to go here and there. Just manage those small pieces first, and then go down to crack the hard pieces. Thank you very much for having me, Nilesh. Thank you very much. It's a great honor and a nice feeling to be here. And I wish all the postgraduate students to be good surgeons. My mission in life is to make good surgeons, as many good surgeons as possible. Thank you very much.
Thank you so much. Ji sir. सर नहीं सर 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 के लिए है सर, बट सर प्रेफर्ड हिज कैप दैट ही ब्रॉट. जी सर लेके भी जाएंगे सर. एक हमारे तरफ से एक छोटा सा टोकन है ग्रेटिट्यूड का सर, सारे सर्जन्स के लिए. सर थैंक यू सो मच सर. कैन वी हैव द वीडियो ऑफ डॉक्टर सत्यजीत सिन्हा सर बिफोर ही स्टार्ट्स हिज सर्जरी?
Hello, my name is Dr.
Thank you so much.
Sinha, and I'm an anterior segment consultant in AVI. I apologize to give me the opportunity to apologize for giving the opportunity to get a demo of Quatera 700. For some time, I have been using a different company's machine, and I was looking for an upgrade. All the other companies which I know of recently have not upgraded their technology, and I was waiting for something new and latest, which I'm very happy to say I have found in Quatera. Out of the last 30 cases that I have done in the past 3 days, I have found the phacoemulsification part absolutely a breeze. Even in the grade 4 and grade 5 cataract, it was just like I was doing a soft cataract, and things were so simple and easy. Even the mechanics and the fluidics and the anterior chamber stability, everything is just absolutely superb. The physics that which they have come out with based on the air bubble, which they have come out with based on the air bubble. The recurring cost is also very astonishing, and the recurring cost technology that they have brought in this is absolutely amazing. You have to really feel it in your hands to know how good this machine is. And I've had an amazing experience over the past 3 days. I've had an amazing of Quatera 700. I'm very happy with the machine. Thank you very much.
Sir, can Satyajit sir be heard now?
Can you hear me now, Vibhuti?
Yeah, we can hear you. So now we have Dr. Satyajit, most dynamic person from Bihar Ophthalmological Society, known everywhere all over India, going to demonstrate on type of cataract. Nilesh, can you elaborate upon the type of cataract,
तो टेबल को नीचे करके.
Yes, sir. So, sir is going to operate on a case of a 63-year-old gentleman who is having grade 3 cataract in his left eye. He is having increased CDI, but the perimetry and all the glaucoma workup was normal. He didn't have any glaucoma that we could note. He is having right now uncorrected visual acuity of 624, an axial length of 23.58 millimeter with an ACD of 2.58. He is having a quite a large length thickness, and his keratometric value is 41.29 at 90 degree and 42 at 180 degree and 0.77 degree of astigmatism. He is going to be implanted CT LARA, an IOL power of 22.5, and it's an EDOF lens. So more will be elaborated by Satyajit sir during his surgery.
Sajid, can you elaborate about the plan of
Okay.
surgery?
Okay, just one thing. I did surgery with Oatly's Faros machine. The company people wanted to tell me this. It's a beautiful machine, not because they asked me to tell this. You have seen how the machine works and how beautifully we can manage hard cataracts with this machine. All Oatly machines, Faros, Cataracts 3, even Easy works in the same way. Thank you.
At the beginning, I would like to first congratulate Dr. Sujit Mishra and Dr. Pradeep Mohanta sir for doing amazing surgeries. I would like to thank Madhavi Netralaya for giving me this opportunity to do a live surgery. Okay, thank you very much. Have a safe flight. So here we have a 63-year-old gentleman, Dilipji, who will be implanting with the EDOF lens. And I'm sitting temporally and I'm going to use a Quatra 700 Zeiss phaco machine, about which I just briefed you in my video. So generally in my day-to-day practice, I use this marker which was made by Dr. Ajay Paul, who we sadly missed today. And that helps me in making a rexis. It guides me. We are doing under topical and now I'm making a paracentesis. It's important that an adequate length should be made. If it's too short, you will have iris prolapse. If it's too long, it will affect your astigmatism. Now you go ahead and fill the anterior chamber. हिलाइए नहीं दिलीप जी, बीच में एक जगह लाइट पर देखते रहिए. Now I use my paracentesis port and I use the spatula to hold the eye, and then I make the main incision, which should be of adequate length, so that the iris also doesn't prolapse and it's not too long. Now once again you go and fill the anterior chamber. I use viscoelastic to enhance my visibility, and I can still see the rexis, the margin on the cornea. So I'm going to use it as a guide. Always tilt the cystotome and go inside so that you don't hurt the main wound that you have made. Go ahead and lift the anterior capsule.
Sorry to do it this way, but I couldn't reach any of the phones. Nagendra sir, your surgery will be next, sir. So requesting you to please be in the OT. I'll request Papa Dr. Kanhaiya Singh sir to please escort sir. Thank you, sir. Thank you, sir.
So we are going to go ahead and make this. If at any point of time you feel the anterior chamber is getting shallow, it's a good idea to fill the anterior chamber with viscoelastic and then continue your rexis. I'm specially using a coaxial illumination so that the red glow and the rexis can be seen clearly. Now I'm going to do hydrodissection, but before doing hydrodissection, in my day-to-day practice, I go to the anterior chamber and first remove the little bit of viscoelastic which is there, so that the posterior capsule doesn't get hurt. Once I have removed a little viscoelastic, then I go behind the anterior capsule and remove the and do the hydrodissection. And you could see the fluid wave just now. Once again, I fill viscoelastic. I hold the eye with my spatula, and then it's very important to make sure that you have rotated the eye well. If you go sideways, you will lose less viscoelastic. It's important to rotate well. Until you get this full rotation, you should not start your phacoemulsification. At this point of time, now I will increase the elimination, move from coaxial to direct elimination, and now I am using this Quatra 700 phaco machine. Sculpt, yes, okay. So we have a linear setting over here. So this is the irrigation. Beach में देखिए दिलीप जी. And we are using a 2.4 incision.
Very well managed. Perfectly circumlinear round axis.
Okay, so I'm just going to remove this bubbles. चॉप पे कर दीजिए. होल्ड का नहीं कर रहा है. So it's important to see that you totally separate the each piece right till the equator. So when you're doing the quadrant emulsification, life becomes easier.
बाहर है सर, आ रहे हैं.
नीलेश रंगटा सर बुला रहे हैं तुमको. Quadrant. Quadrant. So now I'm going to emulsify each piece. Smaller the pieces, easier it becomes to emulsify. The more further away you are from the endothelium, the more clearer your cornea will be next day.
Hello, sorry, I had to go because Pradeep sir was leaving the OT, so I am back. Sir, we can focus on the video on the screen where the parameters are being shown. On the smaller picture-in-picture, sir, it is being shown right now. Yes, sir.
Spatula. So I am generally pretty happy with my bimanual. So I just go ahead and make another parasynthesis, and I use a bimanual. बीच में देखते रहिए दिलीप जी, बस 2 मिनट का काम और है. So now we have to be very careful even when you are removing the cortex. You do not want to catch the rhexis margin.
So it's completely on the surgeon's ease, I guess, to use bimanual
Absolutely,
or
yes.
coaxial. I have seen many good surgeons who are very happy with coaxial, but even I feel bimanual is quite easy and everything can be done in one go.
Once that has been completed, IUL. Ah. Even in the last case in which Dr. Sujit Mishra had to increase the main incision, that was because it was a plus 33 IUL, so which is why it was not going through 2.4.
Yeah, so the company people have informed now that it is from 2.2 to 2.8 because of different adapters. The cartridge size differs, and it was our mistake. I think I overlooked that fact that it was a it was a plus 33 adapter and it required a 2.6 to 2.8 incision, and I didn't inform Sujit sir about that. So now a beautiful implantation of a plate haptic Lisa Lara, sorry,
80 Lara.
80 Lara is being done by Sujit sir. Perfectly well-centered rhexis, so it will be well-centered lens, and then I think the excellent visual outcome should be there. So, so this lens is having aberration neutral aspheric design and advanced chromatic correction for optimized contrast sensitivity. So there will be minimal amount of contrast loss and chromatic aberration.
Excellent surgery.
So now I'll just hydrate the wounds. Thank you, sir. Even at this point, one has to be very careful when you are hydrating. Too much hydration, you can have a Descemet's detachment. Just when you are thinking the surgery is getting over, you may be far from over. So you have to be careful even when you are doing a hydration. It's important that, especially in these high-end lenses, it's important that all the viscoelastic should be removed, and especially from behind the IUL.
So, sir, any particular reason to hydrate the wound before starting the visco removal?
I generally do that because then I have better stability of the lens of the anterior chamber, and then I do it again once I have finished the case. So I do it twice.
So, sir, this machine provides us the amount of leak of fluid that happens during the surgery, and I was just because I don't hydrate before doing cortical aspiration or visco wash. But what we noticed is when we hydrate the main wound and do the cortical aspiration and visco wash, the amount of fluid leak is quite less, and the amount of fluid utilized also is quite less.
राइट साइड में आप लोग देख रहे होंगे वैक्यूम जीरो है क्योंकि मशीन चल रहा है क्यों क्योंकि ऑब्स्ट्रक्शन नहीं था जैसे ऑक्लूड होगा तो वो वैक्यूम बढ़ेगा बिना पेरिस्टाल्टिक मशीन के एक खुली है बाकी दूसरा मशीन होता है वेंचुरी
बीच में देखिए दिलीप जी.
मैकेनिज्म ऑफ एक्शन होता है बिल्कुल ऐसे जैसे कि वैक्यूम क्लीनर होता है वंस इट इज ऑन इट विल स्टार्ट पुलिंग एवरीथिंग तो वो एक सॉफ्ट कैटरेक्ट में लोग उसको एडवांटेज के रूप में लेते हैं लेकिन ज़्यादातर कैटरेक्ट में नया लोगों के लिए थोड़ा रिस्की है क्योंकि हम नहीं चाहते कि एवरीथिंग आए
So,
इसका पैसा मिला
बहुत बढ़िया हो गया दिलीप जी. Thank you so much, Vibhuti. Thank you, thank you.
Level of patience while doing the job. While this is a new machine, I can understand there was issue related to the hold, but you demonstrated a very high level of patience to get hold of nucleus and then do the chopping. So it was wonderful demonstration of this.
Thank you so much. Thank you so much.
sir, sir, yes, sir. We can have Asif sir's talk before we shift to next case because the patient is of left eye, so we need some time to get the patient ready.
Good. Thank you. Thank you for the opportunity.
जी सर जी जी सर हाँ जी सर हाफ हाफ जी सर जी सर जी सर एकदम एकदम सर जी सर हाँ हाफ एंड हाफ कर दीजिएगा
Voice. Hello. Yeah. So first of all, let me congratulate Dr. Nilesh. आज पहली बार आपको जूता पहने हुए देखे तो अच्छा लगा. Otherwise, you mostly in a casual way of dressing. So wonderful initiative. I know you have got many more productive years ahead of you, and you are going to serve Bihar Ophthalmological Society in a bigger way with your acumen of writing papers and also with your surgical skills and the knowledge which you impart. So after going through the multiple surgeries which we have seen, beautiful surgeries by expert surgeons, I'll be dealing with the posterior polar cataract. Some of the videos are little older because my hard disk has crashed. So I'm working with older versions of my surgeries. So a few thing about the posterior polar cataract. It is a round discoid opaque mass, central posterior part of lens. Can be adherent to the posterior capsule or cannot be also, and associated with the weakness of the posterior capsule. So one must remember the adherence is not very complete always, but there is always some amount of weakness in the posterior capsule. So one must be aware of that. So occurrence is 3 to 5 in 1000, bilateral in 65 to 80%. So once you have operated upon a case of posterior polar cataract, you know that the other eye will also have posterior polar cataract. Vice versa, if you see a patient where there is suspicion of posterior polar cataract, grade of posterior polar cataract is not very clear, and there is posterior capsular dehiscence in the other eye, be sure that this patient will land up into complication and remain alert during the surgery. No gender predilections is considered to be subtype of congenital cataract, and there can be some mutations also. So lens may have evidence of small opacities at the birth. Cataractous changes occurs in early 30s to 40s, and that is why it is little crucial when to operate these patients. Affect the vision early, and defective vision and the glare is usually there. So there are two types. One is stationary, where well-defined circular white opacity is present. Concentric thickened ring around the central plaque is present, which appears like bull's eye, which is the more common form. And then the second one is progressive, where there is little bit of spokes present around the bull's eye. So this is the progressive one. This is the diffuse light, and this is the retroillumination, how it appears on the. So there are some classifications also of the posterior polar cataract. One classification is based on the red reflex, that is retroillumination on the slit lamp evaluation. So grade 1 is a small opacity without any effect on the optical quality. Grade 2 is 2/3 obstruction. Grade 3 is opacity in the posterior capsule is surrounded by an area of the further optical distortion. And grade 4 is complete plaque is present, and which will not give you any kind of red reflex. But the other classification is where there is posterior polar opacity associated with the posterior subcapsular opaque cataract. So you can confuse with the posterior subcapsular, and both can coexist also. The second one is sharply defined round or oval opacity with a ringed appearance like an onion, with or without grayish spot at the edge. So there is a bullseye, and then there are leaf which are present all around, and so that leaf is actually holding the capsules also. So this is onion wall appearance. Third one is where there is dehiscence, and that is very complicated one. So Daljit Singh sign is present. If you do anterior segment OCT, you may find a droplet like sign on the posterior capsule, which is Daljit Singh sign, and that is show short indication that this patient might develop complication. Even on the slit lamp, if you follow the posterior curvature, posterior line of the lens, you can identify whether this patient can have a high risk of chances of complication or not. But if there is posterior subcapsular opacity, then naturally that is not present and you may miss that. So type 4 is combination of above, type 3 with the nuclear sclerosis. So examination, a thorough complete examination of the anterior segment. The other examination I already told you. If that has a posterior capsular dehiscence, PCR present, be sure that this patient will have a high risk. Then the slit lamp evaluation, specular biomicroscopy to safeguard, because these patients will have a longer surgical time. There can be damage to the post endothelium also. So please have records. Associated ocular anomalies can also occur in these cases. So anterior segment, if you have got anterior segment optical coherence tomography, it is going to give you information, and this is the posterior segment dehiscence, posterior capsular dehiscence, which will give you a kind of information that is Daljit Singh sign. So posterior polar plate without intact capsule, or if there is a hanging drop sign like this one. So there is a hyperechoic shadow just behind the posterior capsule. That means this patient has some kind of dehiscence, and this patient will develop posterior capsular rupture during the surgery. So thin posterior capsule, earlier it was very high, so the posterior capsular rupture is very high. Earlier it was 30 to 33%, now it has come down with the newer machines, with the advancement in the techniques of the surgery, it has come down. Dilemma regarding when to operate, IUL to advise compliance complicated by the fact the patients are young, and real challenges in avoiding PC rupture. So surgery to be planned only when vision or quality of vision has deteriorated to some extent, which is affecting the patient professional life. Good counseling need to be performed. What need to be explained is possibility of nucleus drop, posterior capsular rupture, long post-operative period, and be prepared during the surgery also for a long operative period, a delayed visual recovery, ND-YAG laser capsulotomy or amblyopia in case of unilateral posterior polar cataract. So these things need to be kept in mind. If you expect the surgery to last longer, please don't hesitate in giving the block to the patient. I personally do posterior polar cataract under block only, because I know these patients may require vitrectomy or other complications can occur. So what are the surgical plan? So because of the stable anterior chamber, phacoemulsification is still preferable. Don't go for ECC or SICS, that is going to give higher amount of complication. Tight adherence of the plaque to the otherwise normal capsule can cause PCR, or second is the posterior capsule itself underlying the plaque is thin. So what are the surgical plan? Most of the PCR occurs during the cortical cleaning, remember that. If there is posterior capsular dehiscence pre-existing, that will develop in the early phase, but even if it is not present, there are higher chances of PCR while you are doing the cortical cleaning. So surgical plan, I will not go into details, but some of the important facts are, if you have to make a capsulorhexis somewhere around 5 to 5.5. Why? Because you want to safeguard the anterior capsule for eventuality if PCR occurs. So you can plant the 3-piece IOL into the sulcus. Cortical cleavage dissection has to be avoided. Only delineation need to be done. No rotation. If you can avoid, don't do the rotation. And there are various techniques of taking out those nucleus chip and flip technique, then the layer by layer phacoemulsification are some of the techniques which you can always employ. Always do the surgery under low vacuum and aspiration rate, and the resultant fragments removed with a stop and chop and a stuff technique. So you have to hold the nucleus chunk, bring it to the tip of the your phacoemulsification needle, and then eat it up. Epinucleus removal is very critical step. So in case of PC rent, there are various ways of dealing with that. If it occurs in the early phase, it is always advisable to do lot of dry aspiration to take out those cortical matter and the nucleus also. If vitreous is present, then it has to be dealt properly. So I'll just go to the video. This is my personal video and my personal technique. I'll not go into the details of what we do during the phacoemulsification because this is old video. So this is a kind of layer by layer phacoemulsification, and while you remove those layers, there are chances of posterior capsular rupture. So if you do, personally I do a 2-port side port, then a 5 to 5.5 millimeter of capsulorhexis is performed. Then I make, usually my main port is made after once I have completed my capsulorhexis. Now the hydrodelineation. You can see beautifully these diamond rings, golden rings are present. So that shows that your hydrodissection is complete, hydrodelineation is complete. Hydrodissection has to be avoided, no rotation, and then chip and flip technique to remove the nucleus. It comes out very nicely because most of the time nucleus is very soft. In type 4, it is nuclear sclerosis, which has to be broken down into multiple small pieces without even rotation, and you can take out the U shape, one piece of chunk from the anterior part, and then the eating up of rest of the part becomes easier. So once you have completed the removal of the nucleus, what you can do is my technique of removal of the cortical matter. What I do, as I explained, onion is something like which is closed one. So if you open it, it is called opening of the onion walls. I do anti-onion peeling. So I try to bring all the cortical matter into the center by pulling from the periphery to the center but not eating it up. I try to preserve the cortical matter till the last moment of time. And what it does, the normal pattern or normal fluidics take care of separation of the posterior capsule from the posterior plaque of the PPC. And that way it saves the chances of PCR in the early phase. So you can see what has happened. These all cortical matter has come into the center, and once it has come into the center, it separates very nicely, and you can remove the posterior caps, remove the rest of the cortical matter very easily. Similarly, here also, so if you this is the posterior capsule, this is the cortical matter, so you can use the Simcoe cannula or even the bimanual cannula. So what I am trying to do, I am trying to separate the cortical matter from the periphery, bring it into the center and just release it. So that way, yeah, you can see very nicely these all cortical matter are getting accumulated in the center. Once it get accumulated in the center, what happens? Already the fluidics has taken care of the posterior plate. And that way the chances of PCR goes down remarkably. Even if it occurs when you have already collected nearly every cortical matter into the center. So the case completes very nicely. So you can see once it has come into the center,
it has already separated now, and this you can see the posterior, this flip, and the central plaque has already separated and it comes out very nicely. So till grade 2 or even in there is no posterior capsular dehiscence, if it is not there, this techniques works very nicely and you can get the surgery done very nicely. If there is presence of posterior capsular dehiscence, you can usually be prepared with the vitrectomy and other thing to take care of the surgery. Thank you very much for your patience hearing.
Very wonderful talk. And the PG students, I think you should have some questions for Dr. Vibhuti. It was a very pertinent topic. Ruchi, any question with Vibhuti? Questions passed. इतना डरा के रखते हुए कोई तुमसे क्वेश्चन कर ही नहीं पाता.
कुछ नहीं. Just one important message to convey.
While you might have watching the surgery, you see any time for the next step, like after doing all the cortical expression, he didn't come out with the irrigation port. So irrigation was on. Because in posterior polar cataract, even at the time of a stromal hydration, you can have a PC rent. So make sure your chamber remains formed every time you come out from the anterior chamber.
After the excellent talk from Professor Vibhuti P. Sinha, I will request Dr. Asif Sahnawaz.
Because in posterior polar cataract, even at the time of a stromal hydration, you can have a PC rent.
Yes, that's what I wanted to say.
Chamber remains formed every time you come out from the anterior chamber.
After the excellent talk from Professor Vibhuti P. Sinha, I will request Dr. Asif Sahnawaz.
Good afternoon, Chairman, panelist, my dear postgraduate students and my teachers. Today, first of all, I want to thank Dr. Nilesh and Madhvi Netrale and Kanhaiya sir to providing me the opportunity to
Can
talk.
we go ahead and
Providing me that opportunity to talk before you people.
Asif?
Yes, sir.
Yes, any announcement from the OT?
We are ready in the OT, sir.
Can I continue the talk 10 minutes
Sir,
or?
Asif, do you mind? Asif, do you mind?
Yes, any announcement from the OT?
Asif, do you mind? Because Nilesh is totally ready. Yes, please. Thank you. Thank you so much, Asif. Thank you.
We take a hardware situation here, and
A short video on toric marking.
this is very important because though we have all the digital markerless system and everything, but they come at
A bit
cost.
louder,
Everybody
Nilesh.
will be having that privilege to have it in the first, second year of your practice, or even in the first few years. I am extremely privileged because of my father, but this is the basic that I used to do when I was working in the charity setup and during my post-graduation days, where we used to do toric marking using slit lamp. It's very simple, efficient, and actually it is very accurate. It is not that you need only toric markerless system for this. So it's very easy to do. What you do is you stain your 26 gauge needle tip with the marker, and you ask the patient to look straight into the eye. Okay. So what happens is the Purkinje image. This first Purkinje image is centered, so that we know that we are in the center of the cornea. The slit lamp bulb and the central Purkinje image, that has to be matched. The slit has to be thinnest. It should not be too wide. It should be the thinnest, and you just so that's what I am doing. I am making it properly central,
and with one hand you just retract your eyelid so that there is proper exposure. Make sure that the image is centered. So right now we don't have a facility to give a view from my eyepiece, but you can see the marking later on when once we are on the table. सीधा देखिए सामने देखिए जी हिलाइएगा नहीं बस लगा के रखिए. So I don't induce subconjunctival bleed right now because it again messes up. But I do a second marking during the OT. Once the registration is done, then I again redo the marking. So that's how it's being done. So from the temporal side it's done, and now I'm doing from the nasal side. Just go touch and just little bit of dimple you do. That's how the stain is projected there. So that's how it's done.
Thank you very much. Now we will move on to the direct telecast from the operating room. We have a 62-year-old gentleman in whom Dr. Nilesh will be implanting a toric IUL, the video of which was just shown just now. And the steep axis are 167 degree with 2.13 diopters. And I'd like to request Dr. Nilesh to please start the case.
So, am I audible? Vibhuti sir, Rungta sir, am I audible?
Vibhuti, can you hear Nilesh?
Yeah, loud and clear.
Thank you, sir. Thank you so much. And I am extremely humbled to be operating among such stalwarts. Like, it's not my place to be here right now, but I am lucky to be here. As we can see, at 180 degree we marked on the slit lamp, we can see one of the mark is still persisting. And now we will try to see the overlay over it. Can we have the DIS with incision? So the incision is supposed to be at 180 degree incision. So can you focus on that screen? So as you can see, that is perfectly on mark. The incision has to be is supposed to be taken at 0 degree, and it is going to be taken at that place only. And this is one thing that I do. 26 gauge needle. So can I have the toric marking axis 6? So that is at 78 degrees. So still we have a good machine and very reliable Callisto, but still what I do is induce a subconjunctival bleed at the axis where it is supposed to be placed. So God forbid if chemosis happens in between or subconjunctival ballooning and we lose the marking from the Callisto, still we will have a landmark to implant diol. So this is the practice that I have inculcated since I started using this Callisto. And now we move on to the incision. Side port, please. So this is a Thomson globe stabilizer that I use for making side port, and a 1 mm angled keratom similar to MVR to make the side port entry. And a 2.4 keratom to make the main wound incision. Since the pupil is little bit less dilated, the patient has been dilated since morning, so we will use some amount of phenocane that gives both dilating as well as some some anesthetic effect. So post-op inflammation will be little less, and we can see some pupillary dilatation that is happening. And since there is a good glow, can we move on to Rexis overlay? So we place viscode and some HPMC below it to make it a soft cell technique, and some visco over the cornea. Just like Satyajit sir, I also like to stabilize my glove with a spatula.
there is little bit of air bubble. It is better if we remove it, but during once I initiate the exercise, I prefer not to uh, do much of. But I think we will have to inject some amount of viscoelastic. Visco. I'm Rexus. I am keeping the Rexus just below 5 millimeter because it's a grade 2 to 3 cataract, but it appears softer than that. So the nucleus tends to come into the AC with fast aspiration, causing more of chattering. So just made it around 4.5 to 5. Not an ideal size for the postgraduates. And now I am lifting the uh, anterior capsule, tenting it up, and then a jet of fluid and tap it from the other side so that the nucleus becomes free. And then a little bit of jet from this side to go from the other way, so all attachments are clean. And then going and doing a hydro delineation to get a golden ring sign if we are lucky. A little bit of golden ring we can see. So that's delineation that is done. The chopper. So the chopper that I prefer to use is an Arul chopper. It is from Appasamy. The benefit of it is a blunt chopper at the end, but the margins are sharp. So we go from equator and then we can actually have a benefit of both sharp as well as blunt chop. And we can see the nucleus is rotating quite freely now. So now I'm starting with my surgery. The settings right now is 50 millimeter of mercury of IOP, that is for irrigation, 120 mg of vacuum. And since it's 120 degree in left, 180 degree incision in left eye, little bit of tilt can happen, but we try to avoid that so that we don't have an wound burn. Starting with my sculpt mode, eating all the cortex above. So we can see nucleus is rotating quite freely, and we'll shave off all the cortex above it. I'll just, please let me know if any defocusing happens during the surgery. So now moving on to chop mode. Now engaging the equator, and now little bit of energy to give an wood cutter chop, not completely done. So going other way around and engaging, and occlusion is happening now, and now a little bit of energy, and now complete cleaving. So now we move. Generally what I tend to do is heminucleus and start eating with phacoaspiration, but since it's a PG training program and we have to go to basics, so I'll try to make 4 pieces first and then start aspirating. So that's this secondary crack done. And now the 4 parts are complete. Now things become very easy. We can just keep getting the nucleus pieces in the central safe zone and just keep eating them up. So I'll just stop in between and put some visco. This is for beginners, it's very important. We need to stop in between and keep pushing visco. Once you are proficient like all the stalwarts here, then we can just do it in one go.
पहला जो चीज ऑन हुआ था वो इरिगेशन का था, तो लास्ट में भी वही ऑफ हुआ, तो
नहीं इतना नहीं, थोड़ा हाँ इतना इतना पे रखिए. सर बेवल अप के साथ घुसते हैं सर. दिस इज bevel up with the irrigation at 90 degree to the bevel.
why do you enter with bevel up? Please explain to folks.
So with bevel up, the energy, the cutting is more. With 90 degree where the bevel is at perpendicular to the probe, the hold is better. But with as the bevel becomes angulated, there is more amount of cutting and less amount of the hold. So around 30 to 45 degree of bevel gives a balance between both that thing. And once the bevel is down, then you don't have the visualization of where the actual the anterior tip is, and it can go and hit the PC. So it has to be bevel up, so you see what you are going to eat.
You answered one step further.
Sir.
Great answer. But my question was one step before itself.
Yes, sir.
Why do you enter the wound bevel up?
The
Has it got
sir,
anything to do with
protecting that? Yeah. Yes, sir. So
each and every step has an पावर जो बीच में बैंडिंग है वो बहुत ही कम है, ये इसका न्यूक्लियस से अलग है.
So now we are in epinuclear mode. So in epinuclear mode, we have more amount of vacuum, less amount of energy. So
regarding
no.
the direction of bevel and chopping for the
So now
try to chop, say vertical chopping, bevel up and bevel down. There will be difference the way to behave. If you are holding using 50 flow and then you are chopping, that whole nucleus will go down, that resistance will not be there. But if the bevel up retains, then that slant, a part of the picotip will act as a resistance from behind and it will give a hold to the indicole that will assist you in pushing your chopper down.
चाहते. So now we are going to use bimanual irrigation aspiration. There is a little bit of epinucleus, but the machine's vacuum is quite good, so and the nucleus is quite soft. हाँ हाथ नीचे रखिए. खत्म हो रहा है, बस 2 मिनट रुक जाइए, खत्म हो जाएगा अभी.
पूरे आईए के दौरान आपका इरिगेशन जैसे रहे, लेकिन एस्पिरेशन का कैनुला का जो पोर्ट है जो इस समय राइट में दिख रहा है, उसका टिप में जो होल है वो ऊपर की तरफ दिखते रहा. ये बहुत इम्पोर्टेंट है, अदरवाइज में कैच पोस्टीरियर कैच सो ऑलवेज बी. बायोमैनुअल का एक एडवांटेज ये भी है कि इसमें सब इंजीनियर करके कुछ भी नहीं रहता है, क्योंकि जो चीज़ अभी राइट हैंड के लिए सब इंजीनियर है उसको आप चेंज कर देंगे हाथ को, लेफ्ट हैंड के लिए सब इंजीनियर नहीं रहा. तो ये इसका एडवांटेज था, शायद इसीलिए इंट्रोड्यूस हुआ. पहले जो था मोनो कोएक्सियल यानी एक हाथ वाला हुआ करता था. बायोमैनुअल में उसी दोनों इरिगेशन को अलग कर दिया है, जो सिंको में दो एक साथ रहता है, दोनों चीज को अलग कर दिया गया है. जैसे अपना आदत तो हर चीज का रहता है, लेकिन एक बेसिक बात ये है कि अगर 360 डिग्री एक्सेस इजीली है तो बार्गेन आप ले लेकिन फिर से रिमाइंड करेंगे, टेम्पटेशन होता है जो नजदीक में है पीछे ले लें, लेकिन नहीं, आपका टिप हमेशा विजिबल होनी चाहिए आपको माइक्रोस्कोप की तरफ, टिप का छेद
Very important points are pointed out. And now we are moving to hydro polish. You can see this irrigation probe is also sandblasted. We got it made especially from Epsilon. They have different design, but we got this design for our hospital. So with this, with irrigation on the side, we can just rub it on PC and all the cortical fibers, small cortical fibers, they are loose and they just, you can see they keep flowing into the
पाइप से जमीन का धूल जैसे धो देते हैं घर का आंगन का, तो उसी तरह से पानी का फ्लूइड इसमें से आपका छोटे-छोटे जो पीसेस जो वहाँ पर पड़ा हुआ है
उसको, हाँ, उसको ये कीजिए पॉलिश
डॉक्टर सुधीर, सैंड ब्लास्ट कैमरा यूज करने के लिए क्या आपका कमेंट है?
access. So now starting with one of the crucial step of toric implantation, that is the IOL placement at axis. I tend to do these cases in under hydro implantation so that visco does not need to be removed and we have less amount of post-op rotation. Sorry, post-implant rotation. सर मतलब ऐसे बोलिएगा सर तो फिर so this is a plate haptic and this can be a mismatch actually because this, yes sir,
at this time we must give a message, I think,
yes sir,
polishing एक ऐसी चीज है जिसमें overdoing नहीं होना।
जी सर, इट्स वेरी इंपॉर्टेंट कि ओवर जिलस पॉलिशिंग में अगर हम इशू क्रिएट कर दिए तो फिर दिक्कत हो जाएगी। आई think there is a mismatch. The rexis is too small for this plate haptic to go, so I'll have to do a visco insertion and enlargement of rexis. So,
usually we are not accustomed to such type of plate haptics, but these are very good style of IOLs, and its stability is said to be more. So most of the time toric IOL is very popular in this plate haptic. क्या डॉक्टर नागेंद्र है?
सर ओटी में है नागेंद्र सर. So you can see with visco it becomes very easy. It
Dr.
just
Sudhir.
glides into the
Dr. Sudhir. Yes, I have used so many plate haptic IOLs. So far as stability is concerned, this is considered to be the best stable into the bag IOL. If you are doing particularly in a toric kind of thing, so there is a minimal chance of rotation into the bag. That is the best part of this 4-point haptic touch, or in other way you can say that is a plate haptic.
Now let me share one of, हमको पता था कि सबसे ज़्यादा एक्सपीरियंस यहाँ पर आपको है, इसीलिए आपका नाम से पूछ रहे थे, और अच्छा लगा कि आप वही बात बोले जो हम बोले, आपको लगा हम गलत।
बिल्कुल सही बोले आप.
डॉक्टर नागेंद्र, you are accustomed to hydro implantation of lens. You are the first in Bihar and Neeraj is second in Bihar.
No sir. there are many stalwarts in Bihar now.
Who may be implanting under IOL, under hydro IOL implantation.
Now, one aspect of plate haptic IOL I would like to highlight.
Only thing I would suggest that you have to make some large rexis. That
yes, sir.
for the plate haptics,
Yes, sir.
It was fall into the a smaller rexis, it is very
Yeah.
difficult to insert the
Yes, sir.
IOL
So
inside.
hydro implantation, it should have
So
been
you
a
always
little,
make
little
larger
larger.
rexis
Yes, sir.
because there is no defined optic size, so you can even go up to 6.25 even.
Yes, sir.
Nothing.
So
So
that was one
there is-
mistake. Probably because it's
Once
my
you are
first live
stuck-
surgery, so I was little more apprehensive and made it more smaller than it was supposed to.
Yeah,
be.
it was looking
So,
like a smaller.
yeah.
Though in a toric IOL cases, but in other C loop IOLs, we used to make a smaller
Yes,
rexis.
sir.
So
Rexis
because
overlay?
it covers firmly from the 360-degree around, so
Rexis?
chances of rotation is there.
DIS?
Don't make larger rexis 5.75 or 5.5.
Sorry,
Even
not rexis,
5.25
yeah.
rexis size
Axis,
in
axis, huh.
a toric IOL, in my opinion, it is best, and I think so. I have not
axis.
done rotation, post-op rotation on any of my
Dialer.
implanted toric IOL cases, which I have been using since many years.
Sir, Sujit here. For the benefit of the postgraduates, I would like to add one of the scenario of my own experience regarding plate haptic lens. What happens when you are aspirating the viscoelastics from behind the IOL? You might have seen that in normal loop haptic lenses that sometimes it comes out of the bag and then we have to again rotate it into the bag. What happens with plate haptics? The full plate may not come out. And especially if your pupil is small, it may go unnoticed.
Yeah.
And when you are doing toric kind of thing and you see there is improper centration. So what happened in my case, that it was not centering, so I pushed it. So what was there, that one part of the this plate haptic was out of bag. So it torn the capsular access margin, and till date, including toric and multifocal IOLs, that is the only complication I have made. So from real life scenario, you have to be careful that in plate haptic lens, if it comes out of the bag, full plate may not come out, and you will be pushing against the capsular access margin. So while washing viscoelastics from behind the IOL, make sure that it is entirely into the bag.
Yeah, that's why it is always recommended to have a slightly bigger axis, so you can, if you use the bimanual irrigation aspiration, then you will have a AGSS behind the IOL in those cases. Because I have seen you have been using the coaxial kind of things for cortical aspiration.
So Sujit sir,
So axis should be is very important factor in planting these plaque haptic IOLs.
So regarding that intracameral injection of moxifloxacin, right now what we are doing, this thing I discussed also with Vibhuti sir, and he also is doing the same thing, is to hydrate the wound with moxifloxacin. This way it stays into the cornea stroma for a longer time and provides, probably provides much more antibacterial effect. And just to point out the PGs, just one point I want to make, this is a very कर लीजिए हाँ बस ठीक है रख लीजिए वही रख लीजिए ठीक can I have the DIS of MIGS is a new thing everybody wants is just have heard about it, but it's very if a good thing, very easy thing to do, very cheap thing to do actually. It's the lens costs around 6,000 that comes from Care Group, and I just wanted to encourage all the PGs to start investing a little bit from your stipend into your instruments and your skills. So right now what we are going to do is just tell the patient, any case you do in your OT, you can just, even if it is pterygium, DCR, you just tilt it to the other side and just, can we focus on the
Regarding Vigamox, intracameral Vigamox, Nilesh, I
yes, sir.
agree with you and Vibhuti sir.
Oh, sorry.
थोड़ा और बेसिक्स में जाएंगे.
उसको थोड़ा सा आगे कीजिए आगे कीजिए वो नहीं है वहाँ से अब पूरा पीछे खींचा गया आगे कीजिए
लगातार 5-5 या 10-10 मिनट पर 5-6 प्रीऑपरेटिव दे देते हैं, तो इसका कंसंट्रेशन
और
सेम होता है जो आप इंट्राकैमरल में, तो जरूरी नहीं है कि आप इंट्राकैमरल दें. और उसके अलावा आप चाहें तो
और जेलन
देने में डर रहे हैं
रहेगा, एलर्जी तो नहीं है कहीं।
ओरोजल।
तो कई बार हम लोग क्या करते हैं कि कंजंक्टिवा के ऊपर डाल देते हैं, तो उससे क्या होता है कि जब स्पेकुलम हटाते हैं तो जो नेगेटिव प्रेशर क्रिएट होता है बैकबोन से, वो खुद ही एंटीबायोटिक चला जाता है अंदर, और उतना काफ़ी है। और आप चाहें तो आप बूंद में डाल सकते हैं या थोड़ा सा एसी में डाल सकते हैं। ध्यान यही रखना है कि अभी तक ये देखिए बहुत अच्छा इंपॉर्टेंट आपको डेमोन्स्ट्रेट किया जा रहा है, ये गोनियोस्कोप है।
ये डायरेक्ट गोनियो लेंस है, 6,000 रुपये का है, कुछ वो नहीं है। अगर आपके अब स्टाइपेंड इतनी ज़्यादा हो गई है कि आप लोग आराम से इसमें इन्वेस्ट कर सकते हैं। जस्ट हाई मैग्निफिकेशन पे रखना है। और किसी भी केस में अभी भी हम करीब 25-30 केस में ये विजुअलाइजेशन करते हैं, अभी तक एक केस में भी MIGS ट्राई नहीं किया, बट आप देख सकते हैं यहाँ पे वी कैन सी द एंगल स्ट्रक्चर, वी कैन सी दैट ऑन द अपोजिट साइड वी कैन सी what the angle is right now. And once you start visualizing for 50-100 patients, then you are confident and you can go and start doing MIGS, which is nothing. You just take a bent needle and just do a sweep goniotomy. So I just wanted to demonstrate that it's very easy to do, and you don't require too much to attain new skill. It's just some passion, similar passion that I have inculcated from all the seniors that that are present over here. And just I wanted to point this out. Thank you so much. थैंक यू सर। हाँ, एक सेकंड एयर बबल डाल देता हूँ कि सर। थैंक यू सर।
अपने केस में विगामॉक्स हम एंटीरियर चेंबर में नहीं डाल करके हम वुंड को हाइड्रेट करने में यूज करते हैं, क्योंकि मेरे हिसाब से वो जो एंट्री वुंड है दैट नीड टू बी
हाइड्रो
मोर एज कंपेयर टू द एंटीरियर चेंबर। एंटीरियर चेंबर व्हाटएवर हैज ऑलरेडी गॉन देयर and got inside, but the wound need to be secured, so the higher concentration is required around the wound. That is most important. ये मेरा practice है।
Actually आप मोक्सीफ्लोक्सासिन हो या जो भी हो, रियल बात ये कि आपका टोटल सर्जिकल कंडीशन कभी भी इन्फेक्टेड नहीं है, राइट फ्रॉम आई इंस्ट्रूमेंट टू फ्लूइड एंड डिस्प्ले, यही असल में बचाता है। मोक्सीफ्लोक्सासिन जस्ट एक मतलब सांप भगाने के लिए जैसे डंडा रखता है, उस तरह की चीज है। अगर जहाँ सांप नहीं है तो डंडा का कोई रोल नहीं है, लेकिन जब
लिटरली सर को चेयर
जैसे जंगल में जा रहे हैं तो उस तरह का आपको डंडा रखते हैं। तो हम लोग मानते हैं कि हम लोग का जो सिस्टम है स्टरलाइजेशन का या फिर पेशेंट का रहने का, उसके चलते ये हम लोग
is very important for the outcome of the surgery. The prophylactic antibiotic as well as prophylactic antibiotic in the preoperative phase as well as the intraoperative phase is just going to give add-on kind of security over and above what you may have already performed.
यही मैं कह रहा था कि आज के ट्रेनिंग में जो ज्यादा जरूरी जो चीज मिस किया जा रहा है वो कि स्टरलाइजेशन प्रोसेस आपको सिखाया नहीं जाता। आप शायद ही इसमें कुछ ही लोग हैं जो ऑटोक्लेव किए होंगे खुद।
क्या बोल रहे हैं?
ऑटोक्लेव करने वाला कितना पीजिए जानते, कभी गए ऑटोक्लेव रूम में, कभी ड्रम पैक किया? ये आपके लिए जानना जरूरी है, क्योंकि जैसे ही आप यहाँ से बाहर निकलेंगे कोई नहीं सिखाने वाला है आपको। अभी जो करना है कर लेना है। ऑटोक्लेव कितने तरह का होता है ये जानना है, कैसे किया जाता है एग्जैक्टली ये जानना है, और खासकर
So with this we come to one of the most dynamic, most craftsman kind of surgeon. Nagendra sir is going to perform the next surgery, I think.
Sir is going to perform on a 54-year-old female who is having a moderately dilated pupil. It is around grade 2 to 3 diopter, and sir is going to implant trifocal IOL, that is AT Lisa Tri on her. She visited us with a vision of counting finger close to face, and she is having an axial length of 22.92, ACD of 3.48, and the keratometric value are 45.01 at 31 degree and 45.70 at 121 degree.
80 Lisa try of 21 diopter is being implanted with an targeted residual refraction of minus 0.2. AC Lisa Tri features 2 additional focal points at intermediate and near distance to ensure a smooth defocus curve for full spectral independence at all distance, and it is having asymmetric light distribution, so reduced halos and glare are there, and its pupil size is it's independent on the pupil size. So, yes sir. Yes sir. Satya Prakash Tiwari sir's, yes sir, secondary IUL. सर के लिए हम लोग पहले से करके रखे हैं एक.
I am audible to everybody?
Yes. Over to Nagendra sir.
As Dr. Nilesh has already enumerated the details of the patient profile, I am going to put the trifocal IOL made by Zeiss, 80 tri, and I am going to register because I have been using the Callisto eye system since many years. So I told the Zeiss people here to give me the Callisto image. This is for the first time I have been using machine in the live surgery. So let's hope, and I pray God for everything goes well. This is the grade of cataract almost 3, white cataract. Here this is a 1 mm sideboard incision. I made 2 so Phenocan. पक्का श्योर ना अलग रख दो कार्बिनोल. I have injected Phenocan. I am big fan of intracameral Phenocan. Once Visco. No, I need Tefan blue. Since I am not getting any glow, so I am injecting Tefan blue to stain the interior capsule. So, the hydro देना, saline देना है. I am going to wash the Tefan blue from the eye, from the interior chamber. Just okay, no problem. Yes. ये क्या है? कितना mm है नीडल का? अच्छा. The side port is slightly different from what I used in my routine practice. Perfectly well stained interior capsule. Give me the Viscot or Visco, anything. Invariably air comes with the Viscot into the interior chamber. No, side main entry. This is 2.4. The tip size is 2.4, so I am using 2.4 keratome, tripolar incision, not filling too much of the anterior chamber because too tight you may end up in a smaller wound tunnel. Perfectly sandwich technique.
Regarding this air bubble, I just wanted to impress upon the whole pyramid that if we are using high molecular weight viscoelastic, especially the
Rhexis.
Because of cohesive property, there will be some retraction at the tip. Now, when you are using that viscoelastic, injecting visco, the initial one will come.
मेरे को बनाना है ला तो 26 गेज नीडल दे दो. Perfectly angled cystotome is very much important in this case, in each and every case of phaco while doing capsular axis. So I do axis from the sideboard most of the time, unless there is a hyper mature kind of thing. And this is the Callisto system, and the marking is 6 mm in size. This initial length of the axis of the capsule is very paramount important in determining the size of the axis. So, if we have a small, then we will always end up in a smaller axis. Since trifocal oil in this case is plate haptic, or in this case this is a plate haptic oil. Feeling too much of cohesive viscoelastics even making axis difficult by not lifting the capsular flap because it is very heavy. So, inject little bit of cohesive. Yeah, hydro. My eye is centered, patient eye is centered on the screen.
It is very well centered and a very nice capsular axis.
I am injecting. I usually inject one point of underneath the and just press it. Visco. Since की देना. I usually rotate with 2 instruments. Idea of rotating multiple times is to dislodge the equatorial lens epithelial capsule. So, prevent those are the epithelium present over there in the capsule fornixes are going to make the posterior capsule opacification, PCO formation. So, dislodging is a good idea. No visco, only chopper and this. My chopper है ना? No, अभी रहने दो. While injecting into the going to the eye, don't start fluid. There may be chances of detachment. So, go inside, then press the eye. This is a very deep eye, deep AC. प्रेशर कितना है यार? कम करो प्रेशर. बस थोड़ा सा दर्द होगा. Somehow it looks to be myopic to me, very deep AC. Yeah, karo chop by. No, it is here. It is definitely is a very deep AC patient. Yeah. आवाज नहीं है माँ.
प्रेशर आ रहा था।
3. Yeah. I am used to of doing, I have experience of machine because I have used Visalis 500 machine for many years. Things are getting too fast. कितना है एस्पायरेशन फ्लो रेट वैक्यूम क्या कम कर दो अच्छा
बॉटल हाइट ही आपका इंट्राक्यूलर प्रेशर बढ़ाता है तो ऐसा ना कि इतना बॉटल हाइट कर दो कि CRBO हो जाए या CRAO हो जाए है ना देखते रहना होता है और
नाइस मशीन
सच में जाना तो आप बॉटल हाइट कम करेंगे तो स्ट्रेच कम होगा जिसका लो स्केलर रिजिडिटी होता है उसमें बहुत ज्यादा
Yeah, I think this patient is having low scalar rigidity because IL power is comes is normal 20 diopter.
That is why, if you remember, at the end of the surgery, I asked the patient whether you are able to see the light or not. What is the reason? Because over high, IOP is very high, then temporarily we will able to observe the flow will be under pressure. So the direct cause of
आवाज नहीं करो अम्मा हिलता है आँख
how much you have hydrated, how much firmly you have formed.
बेसी बहुत डीप हो जा रहा था जिसको दे दो
थोड़ा कोलैप्स किया
या
क्यों क्योंकि उन्होंने बॉटल हाइट कम कर दिया तो जितना ग्रेविटी से आना चाहिए था
अब नहीं करेगा दर्द हो गया
और लेकिन एस्पिरेशन कम नहीं किया तो वो मिसमैच हो गया तो ये छोटा छोटा चीज है जो समय से आ जाता है लेकिन बढ़िया है कि किसी को देख के सीखे आपने गलती करके नहीं सीखना चाहिए दूसरा के गलती से
अब दर्द हो रहा है दर्द हो रहा है नहीं तो डरिए नहीं हो गया है once the moment I enter into the eye the lens iris diaphragm move suddenly backward and anterior chamber is too much deep yeah myopic but here IOL is almost 20 diopter so I didn't expect that this is patient is myopic
the interactive dynamics between the corneal power and axial length that plays. So that's why sometimes not necessarily the lens power will be low.
again we are going to have problem
And when there is more anterior
yeah
pressure, we come across this kind of meiosis. Now you see people is well dilated. So that happens in dynamic anterior chamber.
patient is not comfortable at all during whole of the my surgery yeah लोड करो लेंस आईओपी कुछ कम कर देना
यही रहा है कि हाइड्रो सबको नहीं करना चाहिए हाइड्रो में नहीं डालना चाहिए पहले रिस्को में करिए उसमें ज़्यादा आसान होता है
आईओल डाल दिया
एक्सपर्ट सर्जन कुछ भी कर सकते हैं ठीक है तो इन्होंने क्या किया कि इंटीरियर चेंबर के अलावा कैप्सूल एंटीरियर कैप्सूल और पोस्टीरियर कैप्सूल के बीच का गैप आईए करते समय दिख जाता है
yeah this is trifocal IOL and 4 plaque optic 80 tri it comes with the name of 80 tri no 80 Lisa tri so I implanted under irrigation now I am going to
ट्राइफोकल कैसे काम करता है मालूम है मैकेनिज्म ऑफ विजन
here in this case the Jais people for making me this Jais people for making me this surgery successful and thanks to Madhavi Netralaya and Nilesh where is Nilesh very young dynamic surgeon who dares to do the surgery here and yeah
this IOL also has smooth very nice surgery done Dr. Nagendra but I still agree with Dr. Sudhir that the PG residents should not try the hydro implantation or implantation
sure definitely it comes with the experience
with experience जैसे some कोई
how much force
शासन में खा लेता है तो आप उसका नकल न करें उसको खाने दीजिए शीर्षासन में खाएगा
look when I am sealing it how deep is the AC I think
I think
कितना है AC का क्या है
sir,
depth इसका
AC का 2000
और लेंस थिकनेस बताओ.
Lens thickness भी 3.2 है sir. So
3.2 or
yes
overall,
sir.
no,
So
this is
with combined it becomes quite more 3.4 and 3.4 of both ACD and lens thickness.
so this is a
And
big AC and
23
axial length. How
20,
much is the
23
length?
millimeter of axial length. sir.
23. So this is a big eye.
एक क्वेश्चन मेरे मन में आ रहा है, मल्टीफोकल, ट्राइफोकल, बाइफोकल, कौन सा शब्द बोलना चाहिए इस लेंस के लिए?
किसको?
मल्टीफोकल बोले या ट्राइफोकल बोले?
Trifocal, because we are producing three focal point. Multifocal is a loose term used for trifocal, bifocal both and also.
मल्टीफोकल शब्द में दोनों आ जाए, इसलिए बाइफोकल में तो दो जगह हुआ, ट्राइफोकल में ये हो गया. इसमें दो टर्म और यूज होता है, प्यूपिल इंडिपेंडेंट. इसमें एक और टर्म आपको समझना होगा.
Yes.
ये डिफ्रैक्टिव और दूसरा रिफ्रैक्टिव, दोनों में कोई अंतर बता सकते हैं? कोई?
It is diffractive, refractive technology in both.
उससे आपको लगेगा कि बहुत बड़ा बात बोल रहा है, क्योंकि बड़ा सर्जन है तो बड़ा ही बात बोल रहा है. लेकिन रिफ्रैक्टिव
So this is perfectly.
इसमें आपको लास्ट में सेंट्रेशन
Centration देख लेना है, centration है, yes.
अंदर का जो रिंग है उसके थ्रू कोएक्सियल लाइट जाए.
I prefer slightly higher intraocular pressure, so chances of wound loop would be there.
Congratulations, Dr. Nagar, on a wonderful surgery. Very well done. In the meanwhile, I'll request Dr. Asif Shanawat to please start with his presentation. Prepare his presentation.
बढ़िया है. Nice फेको कटेरा machine. Any question?
आसिफ यू स्टार्ट योर टॉक, नहीं तो फिर लोग आपको रोक देगा.
अब कान बंद, सिर्फ मुंह खुलेगा.
हाँ.
Okay. Thank you.
थैंक यू डॉक्टर नागेंद्र. लिसन टू डॉक्टर आसिफ.
इस पर थोड़ा देर बाद में बात करें. आसिफ बताएंगे. बहुत अच्छा आपके प्रोफेसर हैं DMCH के, और बहुत ही आर्टिकुलेट हैं, और बहुत ही कठिन चीज को कितना सिंपल बनाया जा सकता है.
This lens is concerned. This is 80 Lisa tri featured with two additional focal point at intermediate and near distance to ensure a smooth defocus curve for all spectacle independence at all distances. Near edge, as I already told, it is 3.33 and the intermediate edge is 1.63. So give the very good distance near and intermediate without any halo and all. This is a symmetric light distribution help producing the halo as I told, 50% for distance, 30% for near and 20% for intermediate. And it is pupil size independent, refractive optic design, and having a smooth microphase technology, SMP technology, patented designed by Jai.
Thank you,
minimizing the light scattering. And it is aberration correcting optimized aspheric IOL design. Minus, as you know, the cornea is positive aberration having, and this is a minus 1.8 micron negative aberration. So benefit the patient with a better contrast sensitivity and sharper vision. Also, it has some PCO protection in addition to its square edge design. And the design of the 80 Lisa tri includes Jai's anti-PCO posterior ring to improve results. So it is very loaded in a very smooth injector, and this is a blue mix injector. So you could see the implantation here. It is going very smoothly into the eye and without any problem. This is the package. It comes with this package and design. You can see this lens over here. This comes to my end. Thank you.
Thank you, sir.
Chalo.
Good afternoon, all the dignitaries and postgraduate students present over here. Thank you, Nilesh and Madhvi Netralaya, for providing me the opportunity to talk in front of you. My topic is how to begin your phaco journey. Then first in the list is believe in yourself. Having faith in yourself is the prime requirement to start anything and succeed. Once you believe in yourself, you are halfway done. I am a firm believer of this quote by Marlene Vos-Savant. that to acquire knowledge one must study, but to acquire wisdom one must observe. So observe your seniors, observe their hand movements, observe how they complete a straightforward case, and observe how they tackle complications. Residents in today's era are blessed with easy access of surgical video, even in complex situation by world-renowned surgeon on internet, just a tap of finger away. If possible, record your surgery and try to watch later on. Observe every step in slow motions. It's the best way to learn from your own mistake. Identify the precise instant when your chopper or Sinski tore the capsule. When you saw your surgical video in slow motion, you will able to find your own mistakes in slow motion. Watch the incision construction in slow motion to see why your incisions was leaky. Watch capsulorhexis over and over until you identify when and how an extension to the periphery happened. Then this is the foremost and in my experience is the most critical pearl to choose the right case for a right surgeon according to their skill. Trainees must be handed cases that somewhat match their experience and surgical skill. The small pupil pseudoexfoliation syndrome or subluxation must be tackled by seniors. It is often mature and very early cataract that may pose a challenge for the young surgeons. As discussed in first presentation by Pardeep Mohanta sir and Vibhuti sir, Sudhir sir, a grade 2-3 cataract with well dilating pupil is the ideal phacoemulsification case in early learning phase for residents. Each surgery performed well boosts confidence, and ultimately one wants to challenge himself by choosing more complicated cases. But if a beginner is given complex case that generally tend to land up in a complication, dent their confidence and taking them 10 steps back. So never be heroic in it. Please choose the case according to your skill, and actually it should be done by the consultant, and I do it routinely to allot the cases in preoperative day to my residents. Know in details about patient's clinical and medical history and complete preoperative examination. Recheck and confirm the IOL power and keep as backup one more PC IOL and 3-piece IOL or iris color lens or AC IOL in a standby mode. Then in the operation theater, your phacoemulsification machine is your best friend and your worst enemy. A resident must know how to set up machine as well as how to troubleshoot. One must have complete knowledge of the foot pedal and control panel, the tubings, phacoemulsification console, and most importantly the handpiece. There should be a perfect harmony between your right hand, left hand and your foot pedal. Get acquainted with your microscope and its control. These are already, this has been discussed in previous presentations. Binocular visualization is of paramount importance for any surgeon. Make sure you have the best possible view through the microscope, right position of eyepiece, and the right ergonomic position of your hand and feet in phacoemulsification. If anyone doesn't feel comfortable, then rearrange your position, and it does. Please don't proceed with surgery until you are in comfortable position and have access to all foot switches. There is nothing to say about phakodynamics after Sudhir sir has elaborately discussed each and every step in this topic. Just I want to highlight that conservative use of phaco power is of paramount importance. Excess ultrasound power is absorbed by endothelium and is translated as postoperative stromal edema, both being directly proportional. Perfect incisions are an underrated component of successful phacoemulsification. A leaky wound not only result in flat anterior chamber but can also act as gateway for pathogenic organism, resulting in disastrous complications. As a rule of thumb, never be egoistic in putting a suture if your wound is leaky. One important proverb is, I do not see what mind doesn't know. There are plethora of complications that may occur before, during, and after phacoemulsification. The key lies in identifying and managing them at the right time, but we can only know if we have idea about how to handle it and how to identify it as at correct time. The definition of good surgeon is not the one who never gets complication, but the one who can get out of his complications well. Please, please, please don't hesitate to ask for help. Confidence makes you grow, but overconfidence could lead to a fall. If at any stage of surgery you have difficulty in completing a step, no matter how trivial, always look towards your seniors for assistance. True courage is asking for help, so never hesitate in asking the help from your seniors present at the OT. You will walk with your head held high, knowing you did good towards the patient, which is after all the purpose of any medicine or surgery. Convert your procedure, your phaco procedure if needed. Don't bomb your ego. Well-being of the patient is the purpose of our rigorous training. If you feel incisions are leaky after hydration, no harm in applying a suture. So during surgery, if a push comes to shove, don't think twice before extending your corneal incision and converting to ECC or SICS. Then at last, the take-home message is, patient deserve the best we have to offer. Note down your visual and refractive results. Calculate your SIA, surgically induced astigmatism. Use the result to modify your surgery and optimize surgical results. Thank you. Thank you for your patience hearing. Thank you.
चाहेंगे किसी को कोई प्रॉब्लम हो वास्तव में फैको सीखने पर, तो फैको सीखने का 2-3 उन्होंने सब कुछ बढ़िया से बताया. एक्सेस टू द मशीन बहुत इम्पोर्टेंट है कि नहीं? यहाँ सबको है एक्सेस. तो फिर बचा क्या? आग लगाना है केवल, है ना? और अच्छा शिक्षक आपके लग के लिए आप लोग को मिल रहे हैं, क्योंकि पहले और अभी के शिक्षक में थोड़ा सा अंतर है. पहले शिक्षक भी compete करता था स्टूडेंट से, तो लकीली आप लोग अच्छा युग में जी रहे हैं. तो हमेशा मदद लीजिए, आगे बढ़ के मदद लीजिए. जो नहीं समझ में आया तो ज़रूरी नहीं कि वैसे ही स्टेज से सब कोई गुजरा है और सीखा है. और थोड़ा सा आसिफ से बोलेंगे अपना मिस्टेक से सीखने वाला, उस पर हम एग्री नहीं करेंगे. हम चाहेंगे आसिफ मिस्टेक करे और आप लोग सीखें. ठीक है?
नहीं सर, वो रिकॉर्ड का जो, चूँकि सारे मेडिकल कॉलेज में आप माइक्रोस्कोप माउंटेड कैमरा है और रिकॉर्डिंग सिस्टम है, तो
लेकिन मोटा मोटा बात हो जाता है, ये लोगों में घुस जाता है कि गलती करेंगे तभी तो सीखेंगे. नतीजा क्या होता है कि वो गलती करने को लेकर गिल्ट में नहीं आता है. वो अब केला का छिलका पर पैर रखने से फिसल जाता है. जरूरी थोड़े कि हर बार फिसल के देखबे करें. तो कोई और फिसला है तो उसी से हम सीख लेंगे.
वो सीख लिए तो और बेहतर.
इसीलिए तो रिव्यू ऑफ लिटरेचर, इसीलिए तो आपको बुक्स पढ़ना है, क्योंकि उसमें सारा कॉम्प्लिकेशंस है. और अच्छा ज्ञानी टीचर लोग का बात सुनना है. उसके बाद आग जो है खुद ही फैलेगा और आपके अंदर, और अल्टीमेटली आप दूसरे से अच्छा हो जाएंगे. हम इसलिए बोल रहे हैं क्योंकि हमको पता है कि मेरा आँख का ऑपरेशन आप ही लोग करने वाला है. आप लोग अच्छा से नहीं करिए, सीखिएगा, तो मेरा क्या होगा हम ही जान रहे हैं. चलो, थैंक यू, बहुत अच्छा था.
थैंक यू सर. सबसे बड़ी बात है सर, ईगोइस्टिक नहीं होना है. जब लगे कि नहीं मेरे हाथ से बाहर जा रहा है, कन्वर्ट कीजिए. क्योंकि सबसे अच्छी बात यह है कि जो लोग SICS नहीं जानते हैं उनके लिए तो प्रॉब्लम है कि फिर सूचर डालना या SICS आप पोजीशन चेंज कीजिए और SICS में कन्वर्ट करके आप सर्जरी पूरा
आई अग्री विथ आसिफ कि अगर आप सर्जरी करेंगे तो कॉम्प्लिकेशंस होंगे. डोंट बी शाय ऑफ दैट.
थैंक यू सो मच.
गलती हो मैनेज करेंगे फैकल्टी लोग और आप सीखेंगे.
सही है, लेकिन कितना लोग है यहाँ जो स्टिचेस लगाना जानता है कॉर्निया में? टाँका लगाना 10-0 से कौन कौन लोग जानता है? क्योंकि सर्जन का मतलब होता है काटेगा, और काटेगा तो उसको सिलने जरूर आना चाहिए, नहीं तो बचाओ बचाओ बोलना पड़ेगा. फिर रेजिडेंट खोजो, कंसल्ट, कुछ भी नहीं, आँख में कुछ भी गड़बड़ी होगा, सी लोगे तो आँख बच जाएगा. बस मोटा मोटा बात इतना ही है. तो जो लोग अगर स्टिचेस नहीं जानते हैं तो अब ज़रूर किसी भी चीज़ पर सीख सकते हैं. बकरा का आँख भी रखा हुआ है यहाँ पर. बकरा का सबसे बड़ा खूबी है कि उसका आँख पर ऑपरेशन करें, फिर बाद में खाना खा सकते हैं आप, मतलब मीट.
Nilesh, what is your next program?
Yes, sir. We are ready, sir. Sir, Dr. Tiwari sir is going to, Dr. SP Tiwari sir is going to operate. He is going to use this phaco machine's anterior vitrectomy function. Yes, sir. Sir, this case is a surgical aphakia that was created because of hypermature cataract. So it was created, it was a hypermature cataract that was getting operated at our center, and once the incision was taken, the entire bag along with nucleus and everything came into the AC without any maneuver. So it was just extracted outside through the SICS wound, and then the patient was left aphakic because we knew that an expert surgeon is going to come and manage the same for us. So that is the case. We are going to implant a Technis 3-piece IOL in this patient via the same SICS wound that was created. A pars planar infusion has been planned via a separate line, and anterior vitrectomy with cut rate of around 4,500 is right now being planned, and we will see how the case progresses. Over to Tiwari sir for the commentary.
लिम्स
Yes, sir. Yes, sir. Am I audible, sir? Thank you, sir. At the outset, I would like to thank respected Kanhaiya sir and Dr. Nilesh for giving me this opportunity. I am really glad to be here among you all, and it's an honor to be here and operating in front of all the top stalwarts of Bihar ophthalmology. Irrigation. So my case is a surgical aphakia. It was a subluxated total cataract, which was the nucleus was removed, and now the patient is having aphakia. So these cases are very nice, clean cases of doing scleral fixated or whatever lens we want to implant. So here I am going to, my intention is to implant a scleral fixation. So first and foremost important thing, if any one of the PG is planning to pursue a career in vitreoretina, we are here giving a pars plana infusion source to maintain the anterior chamber, and I have implanted a trocar cannula system, self-retaining trocar cannula system at 3 mm from the limbus, and an infusion line. So before switching on the infusion line, we should make clear that tip of the infusion is visible in the vitreous cavity, to which I have seen, and it is very well visible. So now we are safe, and now we can proceed with the anterior vitrectomy part. Give me some MVR kind of, or yeah. Give me the cutter, vitrectomy cutter. So you all may can appreciate like some of the vitreous strands are visible in the pupillary plane, that is dark pigments inside the vitreous strands, and vitreous is there, a blob covering whole pupillary area. So we need to do first vitrectomy. Now in such scenario we have two options to tricot, yes, if you can give. So we have two options of doing vitrectomy. Either we can go totally anterior. If I am an anterior segment surgeon, it is for me it will be easier to go through the limbal route and doing vitrectomy. If I am retina surgeon, then I would like to go pars plana. Here since majority of the audience is anterior segment, so I would like to go this limbal route. You can see here also vitreous is coming out of the wound, so we can clear the wound as well. You all can see this whole pupil is covered by vitreous.
So I have been.
Yeah, this is the general presentation. If we'll end up with rent also, like while doing phaco surgery, we'll end up with rent.
So as Sujit sir was telling, you inculcate a lot of habits from your mentors while you are getting trained. So sir, I got trained in surgical retina from sir's institute only. Sir has mentored me for this, and he had made me visualize all the vitreous strand in retro and less amount of tricot staining. So I also prefer, but for postgraduate, I think sir, it will be better if they stain with tricot.
Give me tricot. ट्राइकॉट रेडी है, दे दीजिए. जैसे आप लोग देख सकते हैं कि ये वुंड के बाहर प्रोलैप्स है विट्रस. वी कैन सी हियर दिस विट्रस स्ट्रैंड इज देयर.
इसमें आप सिंगल स्क्रीन कर सकते हैं, इसमें पैरामीटर्स का
So while doing anterior vitrectomy, what I would recommend or suggest that we should go as deep as possible and visible in the pupillary plane. हमारा कटर का टिप दिखता रहे और हम लोग को डीप जाना है. In that sequence, and we should always visualize the tip of the cutter so that we are seeing that what we are eating. If our cutter's tip is not visible, then we may cut the important tissue also. इसमें सर कट आईए है, पहले कट है, and I have taken linear vacuum, that my cut rate is static at 5000. So once I am pressing the foot switch, I am getting 5000 cut rate right away, but my vacuum is kept maximum limit at 400, and that is linearly increasing. Once I am keep pressing the that foot switch of the machine, the vacuum or that is aspiration is increasing. So that I can control with my foot switch. Like see, at here the vacuum is less, and now it is increasing, and now it is at maximum. Iris, give me iris, iris repositor. ये पकड़ लीजिए तो मनोज जी। We can see this is the vitreous strand. Cornea, vas cornea. Yes. Sir, the most important indicator is that your pupil should become circular. Like see, this port I have cleared, so from here the iris has become now circular. But here vitreous strand is coming out of the wound, so this there is picking of the pupil. So now see, I am repositing back that vitreous into the vitreous. See, you can very well see this vitreous strand which was there, and now I will remove it from the opposite port. It will be easier, because if I am going through the same port, again that vitreous will come out. So doing a vitreoretinal surgery or tackling a vitreous, or for that matter any surgery, if you are bidextrous, that your both hand works well, then that is an additional advantage for doing any surgery. Like many a times while doing macular hole surgery in large myopes, I am sometimes doing ILM peeling with left hand also. So to train my other hand also, so that I am very much bidextrous and can manage in a difficult ergonomic situation also to do the surgeries. Yes, start writing a small and capital ABCD from left hand with a large pen, like a bulky thick pen with a heavy weight, so that that pen gives a feel of phaco handpiece holding in the left hand, and write ABCD. My handwriting from the both hands, like left and right, I can write ABCD exactly similar from right and left. Yeah, that's it also. And even a spoon, they can use a spoon feeding with the left hand, but writing ABCD from a thick pen is the best thing. Now I am completely clear of vitreous, so I will proceed now with the scleral fixation. Give me a conjunctival seizure.
सर क्लास 8th में थे हम जब एक बैचमेट का हाथ टूट गया था और वो फाइनल एग्जाम नहीं लिख पाया था. सो उस डर से हम लेफ्ट हैंड से लिखना उस समय शुरू कर देते, कहीं मेरा छूट जाएगा तो हम फेल नहीं कर जाए. तो आई स्टार्टेड यूजिंग लेफ्ट हैंड टू प्रैक्टिस राइटिंग टिल क्लास 10th. नाउ इट इज हेल्पिंग मी अ लॉट ड्यूरिंग द सर्जरी फॉर द सेम थिंग.
डाइथर्मी है क्या? कॉटरी 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 मिलेगा? कोई भी, कोई कॉटरी. हाँ, हीट कॉटरी से भी हो जाए, कोई भी कॉटरी यहाँ. सर इसमें सर SICS ऑलरेडी था और कंजंक्टाइवा कटा हुआ था, तो हम उसी को एक्सटेंड कर लिए लगभग आधा 180 डिग्री. अदरवाइज अगर जैसे क्लियर कॉर्नियल ऐसे फाइल करना है फोल्डेबल, तो फिर यहीं पर एक छोटा सा इन्वेलप टेक्निक से कंजंक्टाइवा खोलते हैं. इसमें चूंकि खुला हुआ था तो हमने पूरा कर लिया. हिट है ये, फ्लश करिए. ठीक, हाँ बॉल से ही होगा. कोई सब चीज़ यूज करने आना चाहिए सर. ओहो माता जी रुकिए, हड़बड़ाइए नहीं. लीड पर लगा होगा हीट पार्ट, इसलिए पेशेंट. ओ ठीक ठीक, ले लीजिए. चलिए इतना से काम हो जाएगा. MVR दीजिए, MVR. हाथ नीचे माता जी, हाथ नीचे, हिलिए नहीं, बस हो रहा है. माइक्रोविट्रोरेटिनल नाइफ। जी 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 सर। और ये जैसे इसमें आप लोग को इनिशियल में अगर ऐसे फाइल करेंगे तो टोरिक मार्कर यूज करेंगे, क्योंकि हमने बहुत सारा केस किया है। तो यहाँ एक मेरा है 180 डिग्री करना है, तो बीच में हमने पुरकिंजी इमेज देख लिया और 180 डिग्री मेरा यहाँ आ गया, तो अंदाज से भी मेरा सेंटर हो जाता है। बट इफ सम बिगिनिंग सर्जन इज डूइंग दिस सेम सर्जरी, दे शुड यूज टोरिक मार्कर फॉर दैट। सर साइड पॉकेट बना रहे हैं स्क्लेरा में टू फिक्स द हेप्टिक in the scleral pocket. This surgical technique is called as Gaver-Iscariot technique of scleral fixation. This technique has been developed by Gaver-Iscariot, a renowned surgeon from Germany, and majority of my SFIL I am doing with this same technique. Lens, iris spatula. So I think this is recently done surgery, so I might be able to open the previously done wound. Otherwise, yeah, this wound is open. So दे दीजिए एक ऐसे फाइल फोर्सेप दे दीजिए और लेंस दे दीजिए। थैंक यू। लेंस, हाँ लेंस सीधे मैकफर्सन से। सर ग्लूड आईओएल अब बहुत कम होता है इसमें। जहाँ हम पॉकेट बनाए हैं वहाँ लोग फ्लैप बना के और उसको ग्लू से चिपकाते हैं, तो जी 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 उसका ज़रूरत नहीं है। जैसे हम एक बीओएस ग्रुप में डाले हैं एक वीडियो सूचर्ड ऐसे फाइल, वो ग्लूड होता है, हालांकि हम उसमें ग्लू नहीं यूज करके पॉकेट को भी सूचर कर दिए। बट ये जॉनसन का है सर। Sir, while vitrectomy it generally doesn't go, but if we at this stage it generally goes, sir. Why? Because this pars plana area bleeds always, so it will go. That doesn't matter. Once we are finishing the surgery, generally it disappears. Otherwise, what we can do, we can increase the bottle height to increase the IOP, so then generally it doesn't bleed. Otherwise, this ciliary body region generally bleeds. Like see, this case is bleeding. So this bleed, even if suppose if we have done a thorough vitrectomy, then generally this blood disappears. That doesn't take much time. And one more thing, like vitreous hemorrhage take lot of time to disappear. But once you have a single chamber eye, that anterior chamber and vitreous cavity are the same, then that blood disappears very easily. Why? Because that blood cells are coming to anterior chamber and getting washed very easily. So many a times in a vitrectomized eye, if I am getting recurrent bleeding, vitreous hemorrhage, what I do, generally I do a large PI and cut the capsule also to make a free communication between the vitreous cavity and anterior chamber, so that all the blood which comes in the vitreous cavity comes to anterior chamber and get washed through the trabecular meshwork early and easily. यस सर, जनरल फोर्सेप भी यूज हो सकता है। ये एप्सिलॉन बनाता है SFIOL फोर्सेप करके, मिल जाता है आसानी से, 8-9 हज़ार का होता है सर। कटर दीजिए थोड़ा सा, ये फोर्सेप रख लीजिए। ये जो मेरा एंट्री वुंड था, इससे थोड़ा सा आइरिस प्रोलैप्स हो रहा था, तो दिस आइरिस पिगमेंट्स आर देयर इन द वुंड, सो आई वुड क्लियर विद द vitrectomy cutter. Otherwise, I am done with my surgery. I have to just close this conjunctiva. Can you give me Vicryl sutures? 6 or 7, whatever. 8 is fine. 8 is fine. So scleral fixation has lot of techniques. At least even in my practice, I am using different 8 or 10 kinds of scleral fixation. Like my video in Boss group, that is sutured SFIL 4-point fixation. So that is mandatory if I am doing NIRIDIA IOL, because NIRIDIA IOL whatever available is not available in 3-piece configuration. So that lens cannot be fixed like this. We cannot exteriorize and put in a scleral pocket, because that haptic will that break. So there are 2 eyelets in the haptic, and we have to pass a suture, and those sutures should be fixed to a sclera. So that is called as 4-point fixation sutured SFIOL. So that technique currently I am using just for NIRIDIA scleral fixated IOL in bad cases of trauma where there is no iris. That works wonderfully. Otherwise, this is SFIL. Another technique is Yamane technique. Another technique is glued IOL from Dr. Amar Agrawal. So lot of techniques are there and modifications are there. All these techniques works very well. There is no harm. Whatever you find comfortable, you can try. There is another XNIT technique we call external needle fixation technique of SFIL, where the cornea is very hazy. We can do that. So many techniques are there, and I am using all the techniques whenever I am finding the situation right. Like I remember in Kishanganj conference, I got the opportunity to do SFIL live surgery of BOS, and in that surgery I did that XNIT surgery, XNIT technique of SFIL fixation. यस सर, स्क्लेरा में सूचर देने की ज़रूरत नहीं होती. जो पुरानी टनल भी बनी है वो काफ़ी अच्छी है, स्टेबल है, सेल्फ सीलिंग है. सो आई डोंट थिंक if otherwise needed, then I would have gone for 10 nylon suture for the tunnel, but otherwise tunnel doesn't. जी जी वो देते हैं बहुत लोग, लेकिन हमने देखा है सर कि जनरली स्लिप नहीं करता है. कुछ ही दिनों में फाइब्रोसिस हो जाता है, और द ओरिएंटेशन ऑफ हेप्टिक इज सच दैट it is in the natural alignment of the lens, so that it doesn't slip or there is no chances of slippage. Yes sir, very rightly said. Like I remember my initial days, I used to take 1 hour in a scleral fixation. Here I am doing live surgery, so I am little bit slow, and my surgery is slowed. Otherwise, doing just SFIL doesn't take more than 5-6 minutes. So it all comes with experience. Give me some limbs. Yes sir, developing hand-eye coordination in the microscope. ये मैकफर्सन बहुत दिक्कत है सर. जबकि 1-2 सूचर में बढ़िया से हो. SICS आप लोग करते हैं तो कोशिश करिए कि अगला दिन स्टरलाइज फ्लोरेसेंस से चेक कर लें वूल का स्टेबिलिटी.
कुछ भी नहीं लेके आए तो astigmatism इतना ज़्यादा होगा कि patient will be as blind as he was. तो कितना का astigmatism आता है आमतौर पर
इन्फ्यूजन ऑफ करिए, लिम्स दीजिए,
यहाँ से बंद कीजिए,
इन्फ्यूजन ऑफ करिए.
धीरे धीरे वो स्टेबलाइज होता है तो बेहतर होगा कि टाका लगा दीजिए तो ज़्यादा अच्छा रहेगा. और
So-
इसमें कोई बुरा मानने की बात नहीं है क्योंकि आज यहाँ सीख के जाएंगे तभी तो कल बाजार में अपने आप को लॉन्च करेंगे.
So my surgery is over now.
So,
and thank
sir, Pradeep sir left for airport and he just called. He congratulated you on the surgery. He's seeing it on YouTube.
Thanks.
And sir has one question to ask. There is a space between the initiation of the side pocket where the haptic is being inserted and the exit
Yeah,
point.
yeah.
So will
Yes,
it
sir.
at that place will it cause any
No,
irritation?
that makes insertion easy because suppose we have made a partial thickness scleral tunnel and we have to insert the haptic in that, and if we are bringing our haptic out from the vitreous cavity exactly at the same place, then we don't have a space to bend that haptic and go inside. So that put stretch on that haptic, nylon haptic, and sometime it may break also. So if there is little bit of gap, then it becomes very easy to bring it back at the base of the tunnel and then insert in inside that. So that to make the surgery easier. Otherwise you can make nearer also, but that will make your surgery little bit challenging and you need little more experience to do that kind
handle
of.
that, sir. Yes. So, any question from the main hall?
I am worried because no resident is asking any question. What does it mean? Either you are not interested or you know everything. So no hesitation. Then you should ask. और कभी ये नहीं सोचना है, हम लोग स्टेज से गुजरे हैं, कभी ये नहीं सोचना है कि हम कोई फनी क्वेश्चन नहीं पूछते हैं या लोग क्या कहेंगे, ये कभी नहीं सोचना है. You ask whatever you want, you can ask. This is the platform जहाँ आप कुछ भी कर सकते हैं. दूसरी बात कि डॉक्टर तिवारी का टाइमिंग देख के हम लोगों को वरी नहीं होना है क्योंकि सबका टाइमिंग ये 20 बरस के बाद का है और इसमें टाइम इज नॉट इम्पोर्टेंट. आप जब भी कीजिए प्रिसाइजली कीजिए, आराम से कीजिए, टेक योर टाइम और यही धीरे 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 आपका टाइम शॉर्ट करना है. ऑप्थेल्मोलॉजी में टाइम का कोई इम्पोर्टेंस नहीं. एक जमाना था जबकि आईसीसी दिन भर में 100 करना पड़ता था कैप्स में, आज कहाँ करना पड़ता है, 10 के 15 के बहुत है. तो इसलिए टाइम इज नॉट इम्पोर्टेंट. रिजल्ट अच्छा होना चाहिए और वही लर्न करना है. टाइम स्टिल डॉक्टर तिवारी इज वेटिंग फॉर एनी ऑफ योर क्वेश्चन. SFIL स्टिचिंग ये सब लाइफ सेविंग है फॉर यू, नॉट फॉर द पेशेंट.
Yes, sir. SFIL, I think this is surgery kind of in between the anterior segment and posterior segment. There is no big thing to learn in SFIL. So all anterior segment people, if they have that much time to spend in the OR, they can easily learn. If very senior and busy surgeon, even if they do not do SFIL, they are not worried because they will be sending their patient to a surgeon like us, some of us. And yes, sir. Definitely, sir. And if someone is knowing, then they are double confident that even if something happens, I will manage my own. I think in all medical colleges and training institute, there must be a wet lab, at least with a simple microscope, that so that they can practice hand-eye coordination, suturing, all those things. You can just take a simple foam, mark it with a pen, and put an incision, and that try to suture that foam also. So that will give you a lot of
even a normal surgical loop, and they can practice with table lamp in room also, like with a thicker suture.
सर वहीं जा रहे हैं सर, आप
Yeah.
जो भी रेजिडेंट होंगे सब वहाँ पे क्वेश्चन पूछ सकते हैं, एंड सर विल
Thank.
sir, Dr. Anand, Abhishek Anand sir's talk is recorded, sir, so we can start playing that, and we will try to ask sir to join on Zoom for discussion if it is possible. Yes, sir, just now, just now. After that, the residents can come to the hospital for hands-on. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Okay. Thank you, sir.
हेलो हेलो चेक हाँ यस सर यस सर ओके यस सर
लीजिए सर वीडियो सर के यहाँ हाय हाय हाय
ठीक एक
वीडियो है सही का कोई
Hello, hello, hello.
Yeah, sir, I can hear you.
Yeah. We are getting your voice, and we can see you as well.
I think, yeah, this is the video.
Yeah.
This is the video.
Okay.
I'll mute myself. Yeah.
Okay. I will request all the delegates to take the plates and come and take your seat.
And sound in the video.
Yeah.
खाना खा ली
टिश्यू नहीं जो गाड़ी लाया है वही पहुंचाएगा
है ना वो लोग खा लेता है तो बोल देते हैं है ना
गाड़ी कौन देख रहा है? जो गाड़ी बेतिया से लाया है वही वापस जाएगा ना। हाँ, सबको लाइन अप कर लीजिए,
निकलेंगे
लाइन अप कर लीजिए, उसको बोलिए यहीं पर रेडी रहेगा। वो लोग पार्क व्यू में ठहरे हुए हैं, खाली लाइन अप कर लीजिए और गाड़ी बाहर लगा के रखिएगा। जो गाड़ी लाया है वही पहुँचाएगा।
अच्छा
सब जगह गाड़ी गई बेतिया
काफ़ी लोग तो आ गए सर।
हाँ, अच्छा
22-24 लोग थे और
नहीं अब लाइव नहीं है कोई, लाइव केस नहीं है, वो बैकअप के लिए आया होगा एक दो केस तो ज़्यादा बुलाना ही चाहिए। कभी कभी कुछ अनइवेंटफुल
फ्लो इतना बढ़िया सारे सर्जन के केस में कोई दिक्कत नहीं है
अनइवेंटफुल।
इलाहाबाद हम लोग गए थे ना, पहले केस में डॉक्टर एसपी सिंह जो प्रिंसिपल हैं उन्हीं के केस में कॉम्प्लिकेशन को, लेकिन उनका 25-30 वो लाइव सर्जरी था, उसके बाद सारा स्मूथली चला।
सर हाँ प्रणाम सर। गाड़ी 3 को भेजिए, 4 को होगा।
वाला जो
हाँ एकदम 3 को दिन में भेज दिए।
सब तो इसको
हाँ हाँ
बेतिया वाले से पूछेगा पड़ी
हाँ
कहने मान वो
शंकर जी
हाँ सर, अभी आज एक CME हो रहा है, डॉक्टर कन्हैया सिंह है ना, उनके लड़के ऑर्गेनाइज किए हैं यहीं आदित्य होटल में, उसी में। हाँ लाइव सर्जरी वर्कशॉप। हाँ 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 सब बढ़िया है सर। हाँ
सब लोग
हाँ सर हाँ हाँ वो तो जैसे बोलिएगा वैसे हो जाएगा। हाँ सर हाँ हाँ 3 को दिन में हाँ ठीक है हाँ बिना खाए थोड़ी जाएंगे।
गाड़ी रेडी करवाना बेतिया वाला।
हाँ बेतिया वाला गाड़ी रेडी रहे। वो आप लेकिन यहाँ रहिएगा, बेतिया वाला गाड़ी का नंबर बताइए, इस पर लिख के रखिएगा बेतिया कौन सा गाड़ी जा रहा है, उसका फ़ोन नंबर है ना। ठीक उसको बोल दीजिएगा जो लाया है वो बेतिया पहुंचा के आएगा और रिपोर्ट करेगा आपको। ठीक है पहुंचा दिए और यहाँ गाड़ी लगा के रखेगा। गाड़ी नंबर फ़ोन नंबर लेके हमको दीजिए। सुधीर जी नजर आ रहे हैं चलेगा। रेजिडेंट्स फ्रॉम बेतिया। आप लोग कितने लोग हैं? 3 है ना। तो जो गाड़ी आपको लेके आई है वही आपको ड्रॉप करेगी। ठीक है वो नंबर बता दें। नंबर है उसका है ना।
अच्छा है कर तो जाती आप लोग आ गए रात में
इसीलिए आए थे सर, इसीलिए बच्चा लोग तो निकल भी गया 5:30 पौने 5:30 में निकल गया। लेट हो गया ना अभी इनको बहुत लेट हो गया। डेंस बहुत है सर। लास्ट टाइम हो गया था इसीलिए इस बार एक दिन पहले छपरा हो गया है पटना।
छपरा हो के कोई नहीं, हम लोग हमेशा मना किए।
हाँ नहीं दीघा एक बार बोला ना दीघा पहुँचे हैं हम लोग।
वही है छपरा के चलते आधा होगा। इसको रोक देना, बंद कर देना रास्ता।
ये पुल अगर बंद हो जाए तो
पटना क्लियर
पूरा ट्रक लगा के जाम
एकदम
निकलते हैं।
ठीक है
ये फिर वो भी
हैंड्स ऑन कैसे
सीखने वाले कुछ और भी जा रहे हैं, सिखाने के लिए ढेर सारे लोग।
ये भी एक इवेंट होना था लास्ट में।
ठीक है
आपसे एक दो बार बात हुई है फोन से ही।
हाँ कई बार मुलाकात हुई है।
हाँ
कई बार
थैंक यू
कई बार कॉन्फ्रेंस में ही बात औरंगाबाद से कह रहे हमारे मित्र हैं विरुद्ध जी जी
अब हटा लो नहीं लगा दे अच्छा नहीं लग रहा है अच्छा लग जाएगा निकल गया क्या
to avoid a posterior situation of the terrain means avoid fishing maneuvers that we should undertake. It can be safely done in a very controlled way. You minimize the collateral damage to the pond immediately to prevent enlargement of the keel. And why does it enlarge? Because the bridges collapse and tears apart the two loops of the PCR. And we must respect the capsule. After here, we must prevent to the damage of the capsule and avoid crashing to the peripheral retina and do not create a peripheral brain. And removal of leftover cortex is one of the paramount importance because adrenal cortex is left behind can cause to chronic inflammation in the long-term system. And pollution and separation of iron and avoid environmental strategies to depend on the following things and it can be put at the end of the points that will determine this strategy and what is the optimal strategy. One of the most important is the extent of posterior capsule tear. That will determine whether it is in circus or in the band or will have to adapt to a
सब तो डालेगा ही सब तो डालेगा ही
Blackness of the highlight places color is very important aspect. If you have a very good impact highlight place and you have a small PCR, just to save your capsule access and you can go for it. Now location of the vitreous, whether they are having a small into the vitreous cavity is very important. If it has been small into the vitreous cavity, you can go for a circus-fixated IOL in the same setting, or you can have your retina colleague help you out with the removal of the vitreous along with the circus-fixated, scale-fixated, or an iris-fixated IOL. Another very important is where you are practicing, whether you are practicing, there are vitreous cutter, vitrectomy machines, and a VR surgeon and center is available or not. Also, the availability of alternative IOLs sometimes is not present at the same setting. So these all variables determine how you are going to manage the PCR. One of the earliest response to PCR is the urge for certain instrument, and that should be best avoided. Unplugging the PCR and the chamber. Anterior chamber should be side remaining lens material prior to removal of the IA handles. The surgeon system is position 1. And as the viscoelastic is injected, it should change it to position 2. And the handle can then be safely removed after the anterior chamber is filled. And the viscoelastic is slowly captured there. Now look at this case here. You can see
बैठ जाइएगा तो डॉक्टर सुधीर कुमार को बता दीजिएगा या अपने और पूछने के बाद भी चाहे डॉक्टर सुधीर को बता दीजिए बताइए पहले बड़ा मुश्किल से अपॉइंटमेंट मिलता है उसके बाद बैठ
खाइए खाइए ऐसा नहीं मिलेगा जो मिलेगा सही मिलेगा ये नहीं सीधा ले पैसा हमको दे दीजिए दुनिया रिसर्च कर लेते हैं
बाहर वाला ओवरब्रिज है ना, रेल वाला, जो गिरता है पेट्रोल पंप, बस वहीं हर क्लिनिक उसी में
वही रहेगा वो एरिया प्लस
कल्पना डायग्नोस्टिक एंड इमेजिंग बुलवा पर इसीलिए सब लोग बोला था कि एड्रेस में सर नियर कल्पना, हम बोले उसका में हम क्यों प्रचार करें?
नहीं अभी आप दीजिए
नहीं क्यों नहीं दिए?
वही
गूगल में पहुंचा दिया, हम बोले उसका हम फ्री में क्यों, जहाँ देंगे अपना ऐड सब जगह उसका फ्री में प्रचार होगा। हम उसका एगो स्कूल है, वो स्कूल सारी इंटरनेशनल गर्ल्स स्कूल, कहीं स्कूल कॉम्पिटिटर बिजनेस कै बजे से है, कै बजे से सुबह 9 से 3 कहाँ है? मेरा तो 2 बजे से शुरू है, 11 बजे रात तक, 3 बजे से आप चलिएगा आराम से, 4-5 बजे आइए, लंच डिनर दोनों है, दोनों करके
लंच वाले मत
सब चीज़ है। लंच
सेटअप में घूम लेना इम्पोर्टेंट।
देखिए सर, लंच से शुरू होके हाई टी डिनर सब है, तो जो जिस वक्त आ गया अपना भाई, इसीलिए रखे संडे।
कन्हैया सिंह नाराज
क्या है?
खाली पेट पे कन्हैया सिंह नाराज
बाद में सब मना हो जाएगी।
मसाला हर आदमी का फिक्स कोटा होता है, चाहे अभी खाइए चाहे बाद में,
चाहे पहले खा लीजिए चाहे बाद में। हम देखें जो लोग
प्रोग्राम लंच तक ही रखना चाहिए, उसके बाद आपका अटेंडेंस
इसके बाद तो कुछ नहीं है।
5 बजे तक
रख दिया गया है, जिसको इच्छा होगी अपना संडे को लंच के बाद लोग जनरली भागने में चलते हैं।
कॉन्फ्रेंस में बीओएस में नहीं देते।
इवन जो भी कॉन्फ्रेंस संडे को होता है, लंच तक होता है, लंच के बाद लोग डिस्पर्सल। दो वीडियो सर एक साथ ही चल रहा है, आवाज नहीं
लाइव भी होगा और रिकॉर्डेड भी हरी जी का जो कवर है आप लोग लेट टेबल यहाँ लिए, टेबल लेके मतलब वो भी रखना पड़ेगा ना, ऐसे खुला अच्छा। बधाई हो, बहुत अच्छा
थैंक यू अंकल सारा
लग रहा था कि But he was very confident. No, no, the other टेंशन हमको हम कुछ नहीं कर रहे थे, लेकिन टेंशन हमको क्या होगा
आशीष आशीष सर वेट कर रहे हैं वहाँ रहे तो स्टार्ट बोर्ड साइड यूज आने के बोल रहे हैं कि बैक साइड ज़्यादा बेटर रहेगा बैक साइड साइड वाला बोल रहे हैं बैक साइड ज़्यादा बेटर रहेगा बैक साइड में 30 वाले रहेंगे सर आप भी चलिए ना चलिए ना ना वही काम
Hello. Hello.
For anterior segment surgeons. Hello, I am Dr. Abhishek Anand. I am Associate Professor at RIU and
So thank you, Abhishek sir. It was great to have you. You can join us virtually. I'm Nilesh sir. So, sir का sound वो हो गया है. Sir, your sound is muted now. Somehow. दीजिएगा तो. Hello. Sir, yes sir. Thank you so much sir for taking time out of your family commitment and still joining us virtually. It was really great to have your. Yes sir. Yes. Yes, sir. Yes, sir. Still, after lunch, also all the PGs are sitting. Nobody has ran away, so that is a good sign that your talk was very engaging and everybody heard it well, sir. So, any questions on PCI management from any residents to sir? Sir, yes.
One thing, if nobody has any question, today you all have wonderful surgery. But one thing I would like to emphasize you all that you are all in the early stage of your life. And surgical, one thing you also done is iris fixated IOL. This scale fixated IOL. I am doing for primary anterior aphakia management. I do SFI. But as an anterior segment surgeon, I would say that iris fixated IOL is very easy to pick up and has got almost equal returns. Only issue is that you have need to extend the incision, primary incision size, because it does till now it is not coming in a foldable form. So posterior iris fixated IOL is a wonderful tool that you all should run in a case of aphakia, and it will take only 2 to 3 minutes to do a posterior iris fixated IOL compared to if you have to convert a primary aphakia to a SFI, which will take you around 10 to 15 to 20 minutes. Plus, it has a long learning curve also. There is a wonderful video also, multiple videos also, so I would encourage you all to learn that also.
And sir, regarding the secondary IOL, because mainly for the residents, if like PCR is happening or some complication is happening, will you advise them to stop surgery after taking out the nucleus and just let the AC quiet down if they are not confident in handling that complication at that point?
Yeah, so if you have PCR, then first of all, once something has happened, then you have in Patna or around, you have multiple DR surgeons who can give almost, quiet eye post surgery. So do not complicate if you don't have that expertise. But if you are comfortable and you have the expertise, do a good anterior vitrectomy, put a sulcus fixated IOL, and let the nucleus to be handled by a posterior segment surgeon. Because by using a phaco-frag, as I saw in I illustrated in the last case, you can take out any grade of nucleus. I just did a grade 5, grade 6 nucleus also, so no worries for that. But do not do that, do not compromise the capsule, do not do fishing, do not create a posterior capsular, peripheral tear or something like that. So that will be avoided, but once you learn, keep learning in the field, learn the art to do an anterior vitrectomy. It is very important. It's sad that many institutes don't have the anterior vitrectomy, but that is something we should all have. And I think cutting with scissors and, using the earbuds as a wig to know the vitreous, because it keeps, you keep pulling the vitreous and it will keep coming. So you should have an anterior vitrectomy, and that is what I would advise. Use the anterior vitrectomy to do a good vitrectomy, and if you have expertise, put the IOL in the sulcus. If you don't, close the eye, put a suture. That is very important. I have seen many guys not doing suture, so that is not good. So you should suture the primary incision before sending it to anybody.
Thank you so much, sir. Thank you so much for all the insights. And next time we hope to have you physically present in the next meet.
Sure.
Thank you so much. Thank you so much.
Thank you. Bye. Take care. All the best. And it was a great festival. Great surgical festival.
Thank you, sir. Thank you so much.
Thank you. Bye. Take care.
Yes, sir. So we are. We are now over with all the talks and all the live surgeries, and all the residents who are interested in all the residents who wish to have a hands-on on phacoemulsification and anti-vitrectomy, I request they can just join us at Madhvi Netralaya premises. Ashish sir actually has to leave, so he is waiting for you guys to like get the briefing, and then you can have a hands-on. So anybody who wants to come, please come to Madhvi Netralaya. Yes.